everyone. Are we on? Good. We're going to get started now, and I recognize that people will still be coming in. Because we're in the midst of our final exams, we will also recognize that there will be probably students and faculty who will also be coming in and out over the next 4 hours as we go through our symposium. So we'll just have to deal with some of the movement going on. So I'd like to welcome you all here to our annual symposium brought together by the Center for Mental Health Initiatives. And I'm excited to bring together an expert panel to help us learn about and discuss issues related to global mental health. So first, I want to acknowledge the generous funding from the Center for Mental Health Initiatives, a program that is within the Department of Mental Health here at the Bloomberg School of Public Health, which is directed by the chair of our department, Dr. William Eaton. And the Center for Mental Health Initiatives is a program that is really supporting initiatives around improving the lives of people with severe mental illness, particularly here in Baltimore City as well as globally. It also has a mandate to investigate issues around psychopharmaceuticals and a component on reducing disabilities associated with mental illness in low-resource settings. A year ago, after the last symposium, Dr. Eaton approached me and offered up the opportunity to put together a symposium on the topic of my own interests. So I'd like to spend a few minutes sharing how we came to this topic of today's symposium and why the topic is actually phrased as a question, which is, can developing economies afford to ignore mental health? And I put it out there because it's something that we need to grapple with. So to tell a little bit of how we got here, I started my academic career with a focus on economic development and moved into the field of public health with an eye towards utilizing health as a catalyst for development. And together with friends and colleagues who have gone on to work in international education, economic programming, and other areas, we all have in common this ideal to help individuals, families, communities, societies in difficult situations to improve their lives. So the idea being that health is one way to get there within a whole range of disciplines focusing in on development. So within the domain of health, I decided to focus primarily on mental health issues, and together with my collaborators from the Applied Mental Health Research Group here at Hopkins, we have been fortunate to have worked with many different collaborators around the world, some of whom are in the audience today, and to understand the types of programs that can improve the mental health of people around the globe, particularly populations in post-conflict and low-resource settings. And our work has focused on both the development and testing of cross-cultural measurement, but really moving towards the adaptation and testing of programs and interventions to reduce the symptoms of mental disorders and distress, really in order to alleviate the dysfunction that accompanies these disorders. It is this link between mental health and impaired functioning that I think makes mental health such an important topic when we think about development as a bigger realm of study and growth. We have a lot of research that has consistently shown that mental health problems, however they're defined, disorders, diseases, distress levels, that mental health is related, is causally associated with disability, regardless of context. So whether it's in high-resource settings, low-resource settings, there's this intricate connection between mental health and disability. A logical conclusion, therefore, is that countries or regions with even relatively modest rates of mental disorders are dealing with a critical mass that is functioning at less than their full potential. So when we're thinking about severe disorders all the way to the range of common disorders, less severe disorders, we're talking about potentially a population not functioning at a level that is needed for development. But while we see this is sort of the case in the literature, what we see is that it's not the case that mental health is a priority for most of these countries, and organizations in terms of how to improve development and functioning. So I suspect that a major reason is for this lack of logical conclusion is a lack of data to support the assertion that investing in mental health at the government level and mental health interventions will significantly improve functioning, both at the individual level and the family level and the community level. So I question the extent to which we have the ability right now, with the evidence we have now, to inform governments, to inform agencies that provide services as to what services they can provide and should provide, and where the evidence is. What variations are there? Is there differences based on high-income countries, middle-income countries, low-income countries, resources available, economic resources, human resources, rural, urban, populations? What do we know about children versus adults versus severe mentally ill versus refugees versus post-conflict populations? And it's this gap in our knowledge as to what works for whom in what setting that is a difficult thing for making recommendations about what types of services and whether mental health should actually be a priority. So given what I expect is this relatively limited amount of information, given what I know from the literature and from our own work, what advice can we offer to governments or an agency trying to decide how much to invest in mental health versus how much to focus on other priorities? And then what are the next steps? So if we have limited information, do we just go with that limited information, or do we actually put together a research agenda to gather more information? What are the next steps to help us address these gaps? So all of these questions came together for the development of this symposium. So I was able to start to address this issue by gathering a whole series of prominent experts in this field, and to help us as a group learn about these issues and grapple with these issues as we begin to discuss a path forward. So that's how we got here. So to move on to now the actual symposium, I would like to introduce our 4 speakers. The first 2 will present for about 35 minutes each, and this will be followed by a short break. On return, the other 2 presenters will speak, and then we'll all come together for a question and answer and discussion period. And I intentionally left a long time, a full hour, for this discussion period because I want us to think about and grapple with these issues and be able to figure out what's the next steps. So I ask that you hold your questions until the very end, unless there's specifically a question just for clarification, so that we can all come up and be part of that discussion. Please note also that the symposium is being audio taped and videotaped to put it online, and that there are members of the press in the room. So please note any comments are actually on the record, since it's going to be kept. And let me start with introducing our speakers. So our first speaker is Dr. Vikram Patel. Dr. Patel is currently a professor of international mental health and a Wellcome Trust Senior Clinical Research Fellow at the London School of Hygiene and Tropical Medicine, where he is also the Joint Director of the school's Center for Global Mental Health. In addition, Dr. Patel founded the India-based NGO Sangha, a mental health NGO which won the MacArthur Foundation's International Prize for Creative and Effective Institutions in 2008. He was an editor of the Lancet series on global mental health in 2006, and of the PLOS Medicine series on packages of care for mental and neurological disorders in developing countries in 2009. Dr. Patel led the efforts to establish the Movement for Global Mental Health, which is a network of researchers, practitioners, advocates, and institutions that aims to improve services for people with mental disorders worldwide. And if you're interested, I would advocate that you get online, search for the Movement for Global Mental Health, and add yourself to the list of the movement. Following Dr. Patel will be Florence Bangana, a psychiatrist from Uganda with extensive experience in mental health policy and planning. In Uganda, Dr. Bangana worked to establish the mental health unit in the Ministry of Health, within which she developed the standards and guidelines for mental health care and got mental health included as a component of the Uganda minimum health care package. Dr. Bangana previously worked at the World Bank and currently is a research fellow at the London School of Economics and at the Macquarie School McCrary University School of Public Health. After the break, we will hear from Martin Knapp. Dr. Knapp is a leader in the field of mental health economics and social care policy. He is the director of the Personal Social Services Research Unit and the National Institute for Health Research at the London School of Economics. He is also a professor of social policy and co-director of the London School of Economics Health and Social Care Program. Dr. Knapp also holds an appointment as professor of health economics and director of the Center for Economics of Mental Health at the Institute of Psychiatry at King's College London. And finally, we'll hear from Shekhar Saxena from the World Health Organization. Dr. Saxena, a psychiatrist with 30 years of experience in mental health services research and program management, is the director of the Department of Mental Health and Substance Abuse at the WHO. He was an author on the World Health Report 2001 on mental health and an editor and author in the Lancet series on global mental health. He led the development of the WHO's Mental Health Atlas and WHO Assessment Instrument for Mental Health System, WHO AIMS, which is being used now in more than 80 countries. And currently, Dr. Saxena is responsible for the implementation of the WHO's Mental Health Gap Action Program to scale up mental, neurological, and substance use disorders in low and middle-income countries. So with that introduction, I would like to invite our first speaker, Dr. Patel.
So the first challenge is working out how I get my slides on, which I just picked my name. Ah, okay. All right, thank you. Thanks. Thank you. I hope I don't need more help with my presentation, Judith, but if you could just stay here, that would be useful. I'd like to start by, first of all, thanking Judith and the organizers here for having invited me today, and also a word of apology for those of you who heard my talk 2 weeks ago at the NIMH. I have nothing new to say in 2 weeks, and it's a good time for you to go check your emails, have a cup of coffee. What I'm going to do is I'm going to try and give a kind of an overview about this discipline that I think many of us here in this room have been very actively involved with over the last several years, and hopefully leave at least those of you who are students or thinking about careers in this field with a sense of optimism and hope that this might be a very bright new career in global health. I want to start by, first of all, reminding ourselves that the field of global health itself is actually fairly young. Only last year, authors such as Jeff Copeland and others actually had the courage to describe what this field was. If you remember, those of you as old as I am will remember that in fact the field used to be called international health, or even longer back, hygiene and tropical medicine. In fact, my institution in London is called that. And the word global health seems to have appeared about 7 or 8 years ago. This is the definition used by Copeland et al. And I think the main distinction that the authors wanted to make between global health and international health is summarized on this slide. So global health was concerned with disparities in health outcomes, not just in poorer countries of the world, but indeed in all countries, such as, for example, back here in the US. It was also concerned with the determinants of health that were global in their scope, for example, climate change or migration, in addition to individual level determinants. There was emphasis both on the prevention, which was of course a key issue in international health, but also on excellence at the level of individual clinical care. And finally, and this is of course very, very relevant for our field of global mental health, that the priority setting exercise in global health was to be determined by the burden of disease, and not, as in international health, by which diseases affected them in developing countries. So now, when you actually applied a priority setting based on burden of disease, well, mental health, it turns out, began to look like a fairly important condition or set of conditions to focus on. So global mental health really is simply the application of the principles of global health to the specific discipline of mental health. And here, and I'm sure Shekhar will talk a little bit more about this in his presentation, when we talk about mental health, particularly in the low resource context, we're really referring to priority disorders that affect the brain. A whole range of conditions, as you will see shortly, that are traditionally within a medical or biomedical model classified as mental disorders, neurological disorders, or substance use disorders. And so we have this rather awkward acronym of MNS. If anyone has a better one to come up with by the end of the symposium, then I think they're a leader in this field. Now, the primary focus is reducing mental health inequalities within and between countries, but in fact, the most striking inequities are the disparities in the provision of care and the respect for human rights for people with mental disorders between the richer countries of the world and the poorer countries of the world. And that will be actually the focus of my presentation. Now, having said this, of course, those of you who are working in richer countries will also be aware that there are very glaring inequities even in rich countries, and maybe some of the ideas that I will share with you today might in fact have some relevance to how one might reduce inequities within rich countries. So I'm going to start by just giving us a kind of a brief overview of the scientific foundations of this discipline, then tell you about some important new initiatives and opportunities in the field, and then finish off with just my view of what might be some future directions where the field might go. I identify four major scientific foundations of the field of global mental health. And in very brief terms, I will go through some of the most important or salient findings that each of these different foundations have provided us. The first is cross-cultural research. This is easily the most important starting point for any discourse on global mental health. A rich foundation of research on mental illness in different cultures, in different contexts, in different countries, driven by multiple disciplines, in particular medical anthropology, the clinical mental health sciences, and epidemiology, describing a whole array of features of mental illness: the experience, the phenomenology, the help-seeking behaviors, the explanatory models in an array of different cultures. Iconic authors like Leighton and Lambo come to mind when I think about the real leaders of this field over the last several decades. What are the key findings of this very substantial body of research? Firstly, that the major categories of mental disorders can be identified in all cultures, and whereas cultural factors profoundly influence the expression of these conditions, certain core psychopathologies can be found for most of these conditions in most places. Secondly, the research methodologies that borrow upon both epidemiological measurement as well as ethnographic descriptions need to be integrated so that the evidence that we generate is not only locally relevant, but is also internationally comparable. And lastly, that no matter where you go, social disadvantage is a bedfellow of mental ill health. There is indeed a vicious cycle of disadvantage and mental disorder. Here are some landmark publications that I direct your attention to. The World Mental Health Report from Harvard Medical School, which drew our attention to social exclusion and mental ill health. The World Health Report of 2001, which synthesized all the knowledge on mental disorders from a global context, and was the first time the WHO devoted its annual report to this subject. And most recently, I think a real landmark document really, which goes, of course, much more than mental health, examining the social determinants, and particularly the structural determinants of ill health in a very provocatively titled report from the World Health Organization, Closing the Gap in a Generation. Of course, the gap being referred to here is the gap in the health outcomes between the rich and the poor. The second important foundation of evidence is the evidence on the burden of disease, and for this we must thank Chris Murray and his colleagues at WHO and Harvard Medical School for having invented the metric of the DALY, a metric which combined the influence of a health condition on both years lived with disability as well as years lost due to premature mortality to produce a single metric which allowed us to compare very different conditions side by side. When one did that, this is the latest set of estimates that I could get my hand on from the Global Burden of Disease of 2006. What you can see here is that the overall burden of MNS disorders is high in all regions of the world. Of course, it's lowest in the African region because proportionately there's a much higher burden of HIV/AIDS and other infectious diseases. But in all the other regions of the world, anywhere from 12 to a quarter of the total burden of disease is due to neuropsychiatric disorders. And then if we cut the world up into income categories, you can see in the poorest countries of the world, the low-income countries, fully 10% of the total burden of disease is due to neuropsychiatric disorders, going up to nearly a quarter or more in the richest countries of the world. So these conditions are very disabling. Now, which are these conditions? I've extracted the top 10 brain disorders, as it were, that account for this disability. And you can see you've really got conditions here that span the biomedical specialisms of mental disorders, neurological disorders, and substance abuse disorders. And that, again, brings me back to the earlier point about us needing to be dealing with these three different groups of conditions together. In particular, in childhood, you've got two very unique sets of conditions that affect childhood. Right up on the top is intellectual disability, very often disregarded in our programs for mental health, and other neuropsychiatric disorders, which include other forms of developmental disabilities, such as pervasive developmental disabilities. Now, for far too long, we've often thought that, disability is all very well, but really in developing countries where people are dying in very large numbers due to preventable causes, really can we park our scarce resources behind conditions that only disable? Well, it turns out that mental illnesses can also kill. In this particular analysis, which looked at the causes of death in young people, arguably one of the most productive age groups in any part of the world, and published just last year, suicide turned out to be amongst the 3 leading causes of death in adolescents and young people in all countries, including, indeed, in the poorest countries of the world. One of the other leading causes of death was accidents, many of which were fueled by substance use. So, in this very important demographic group, at least, mental health problems were a leading cause of death, accounting for at least 2 of the 3 leading causes of death. The other one, of course, was HIV. In older people, dementia is one of the leading causes of death, and even after you remove suicide as a cause of death, people with schizophrenia are 2 to 3 times more likely to die than people without schizophrenia from the same population. And of course, a key reason for this is inequity in access to medical health care. That is, access to health care when people with schizophrenia suffer from chronic medical conditions like diabetes or heart disease. In the Lancet series on global mental health, we also examined the impact of mental illness not just on disability and mortality due to mental illness, but the interface between mental illness and other health concerns. For example, cardiovascular disease, diabetes, child growth and nutrition, and HIV/AIDS. As the title of this paper suggests, no health without mental health simply meant that the evidence is very strong that there are very close and very complex interrelationships between mental illness and a whole range of physical health problems, so that you cannot really address many physical health problems without also paying due attention to mental health needs of individuals. The third important foundation, so the first is the study of mental disorders across cultures. The second is the description of the burden and impact of mental disorders. The third important evidence, of course, is what can we do about these conditions? Now, this is interesting because right up till the World Health Report of 2001, we knew very little about what we could do for mental health problems in low-resource settings. Much of in fact, all the evidence up until then having come entirely from developed countries. The situation changed in the years after that, and sufficiently enough, in fact, for us to be able to synthesize what the evidence was for the cost effectiveness of a range of different treatments for a wide variety of mental, neurological, and substance use disorders for the Disease Control Priorities Project, which was published in 2006. And then we further updated this, looking at the evidence both for treatment and prevention for the Lancet series in 2007. Now, it is interesting, of course, that the very first randomized control trial for any mental disorder from any developing country was only published in 2003. And that tells you how young this particular field of research has been. Now, in spite of the evidence of the availability of cost-effective treatments, the treatment gap, which is to say the gap between the number of people living with a mental disorder who could benefit from treatment and actually receive treatment, is over 50% in all countries. That includes, I'm told, in the US, but reaches an astonishing 90% in low-income countries. And when I use the word treatment gap, I'm not talking here about mild forms of mental health problems. Here I'm talking about people living with serious mental illnesses like psychosis. Now, one of the very important reasons for this treatment gap are the resources available for mental health care, which was reviewed by Shekhar Saxena and colleagues for the Lancet series in the second article of the series. These authors looked at the availability, distribution, and utilization of a range of different mental health resources, but I think we can all agree that perhaps the most important resource, at least at the level of individual care, is the human resource. One of the good things about mental health care is we do not, in fact, need expensive buildings or technology to provide mental health care. What we actually need is a skilled human being who is competent to diagnose and deliver mental health treatments. Unfortunately, as you can see from this slide, there is a great inequity in the availability and distribution of mental health specialist human resources according to which part of the world you live in. So here you can see 4 different kinds of specialist human resources: psychiatrists at one end, social workers at that end. And for each of these categories, we've got the availability, that is the number of this human resource according to unit of, as a ratio of the unit of population, for 4 different regions of the world. And the poorest countries in the world, as you can see, actually don't even appear on this chart, which is scaled to the richest countries of the world. If you do a simple calculation, there's roughly 300 times more mental health professionals here in the US than there might be in India, where I live. In fact, someone has calculated that there are more psychiatrists of Indian origin in the US than, in fact, there are psychiatrists in the whole of India. So we really have a challenge here, which is how in heaven's name are we going to deliver treatments for mental health problems in a context where we have such few mental health specialists. And we need to learn from our colleagues in other areas of global health, because of course this human resource shortage is not only unique to mental health care, it's true of all the different biomedical disciplines. And what do people in obstetrics and pediatrics and other disciplines do? Well, they start shifting care from specialized human resources to less specialized human resources, a procedure that has been more recently called as star shifting. But of course, star shifting has been going on for decades. Consider China and its barefoot doctor model. It's only a new term to describe what's been going on for a very long time. The evidence is pretty strong for task shifting in many areas of global health. This Cochrane review examines the evidence for conditions, infectious diseases, for example. What about our field in mental health care? Earlier, I told you that we have some reasonably good evidence about specific treatments, but the question really remains, how do we deliver it in settings where we have very few specialized human resources? Well, here is some exciting new evidence. Well, this first trial, of course, is led by Paul Bolton, who is sitting here in the audience and works in Hopkins. 2 trials from Uganda where he and his group were able to demonstrate that lay people were able to deliver a psychological treatment called interpersonal therapy for depression in adults as well as in adolescents who were living in refugee camps. 2 trials from Chile, which were targeting women living in poorer districts of the capital, Santiago. The first trial with a general population of women attending primary health centers, and the second trial targeting mothers who were depressed. Again, both of these are showing very large benefits through a community health worker-delivered group intervention that included a step care model. But what's interesting about this trial are 2 things. First of all, that these women who are taking part in this group exercise are being led by a woman who was a service user herself and recovered, and a good example really of volunteerism of people who are living with mental illness. And the second important point is that this particular intervention is now part of the National Depression Program for the government of Chile. This trial is one of my favorites, not only because it was carried out in my region, but also because, in fact, the intervention was not delivered by a research counselor, but indeed by existing lady health visitors who are the community health workers charged with maternal and child health care in one of the poorest countries in the world, in fact, one of the poorest areas of a poor country in the world, Pakistan. The other reason why it was great interest, apart from showing a very large benefit in recovery rates for the mothers who were depressed, they also were able to demonstrate benefits for the babies of those mothers, for example, increasing coverage of immunization rates, showing, I think, perhaps for the first time from a developing country, that treating mental health problems has added benefits for other people within the family, in this case, the newborn child of the mother. This is a non-randomized evaluation of a community-based rehab package for people with schizophrenia in, again, one of the poorest districts in India. And this particular package, again, led by lay health workers who were trained in a package of CBR over 2 months, is now being evaluated in a randomized controlled trial in 3 sites in India. And my last, and again, something I'm very pleased about, because this particular example of a community health worker-supported intervention supporting caregivers of people with Alzheimer's disease and other dementias won this year's Alzheimer's Disease International Prize for innovations in psychosocial care for people with dementia anywhere, not just in developing countries. Now, it's this kind of exciting new delivery evidence that has been synthesized together in a series of articles describing packages of care, package of care basically reflecting multiple components of care through different delivery mechanisms, which is, of course, a characteristic of mental health care. Mental health care is not about a pill or a psychological treatment. It's about many, many different elements that must come together involving many different players in the health system. And this idea of the package of care lay at the basis of 6 evidence-based syntheses for 6 different mental, neurological, and substance use disorders. And of course, in an effort to try and integrate these different packages of care to create a single population-based model of care, we've got a plan that is currently being considered by the government of India for a population of 750,000 people where I live in Goa. The fourth piece and final foundation of evidence is human rights. Well, colleagues in London have tried to apply a scientific lens to measurement and description of the lived experiences of people with mental disorders. This particular study, for example, documents the experiences of people with schizophrenia in 27 countries and finds very high rates of stigma and discrimination in all these countries. But one can go beyond the evidence that is presented through quantitative numbers and look at the lived experience in many different ways. For example, the photographic images of people who live with mental disorders, sometimes in the most horrific conditions, sometimes indeed in the institutions that have been built to care for them. It is these horrors which continue to be perpetrated in many developing countries of the world, which when combined with the resounding silence of the global health community was referred to by Arthur Kleinman as a failure of humanity last year. The global spotlight on these continuing horrors was again brought to our attention just a few years ago in this Time cover story, which documented the conditions of care for thousands of people with mental disorders who apparently had just been forgotten in hospitals often built during the colonial period in South and Southeast Asia. It's not only adults who are treated in this manner. Here is a hospital for mentally disabled children. And it's not just Asia and Africa where you will see these horrors. Here is a cage bed from Eastern Europe. And this image really, I think, depicts best what we mean by the failure of humanity. This is another hospital in Eastern Europe, where you can see this gentleman here is having to drink water out of a bucket because they haven't bothered to place any crockery in his hospital cell. Now, if this is the kind of care you're likely to get when you land up in a mental hospital, it isn't surprising that most people don't go there until it's the place of last recourse. However, one must accept the fact that many people with mental health problems, particularly serious mental health problems, have difficulties in self-care and behavior difficulties. Some families are forced to resort to this kind of care in the absence of any other humane form of care. This picture is about a young man with schizophrenia in a northern Indian state, showing what his family actually does with him every day before they go off to work in order to protect himself. Or this young man with a mental disability and epilepsy in a Central African country, and this perhaps tragic picture where you can only see the woman by her hand through a door which really marks the cell behind which she lived for 16 years. This photograph was only taken actually a few months ago in the Western Pacific region. It's this kind of foundation of evidence that really lay at the heart of the Lancet series for global mental health, which ended with a call for action to scale up the coverage of services for people with mental disorders in all countries, but with an equity lens applied to it, focusing on the low and middle income countries of the world, based on 2 principles. First, we had to be guided by science on what works best, but also we had to pay equal attention to strengthening the human rights of people. We had to put a moral value on the rights for people with mental disorders for a dignified existence. What are the actions that have taken place since the call for action, this particular series, was published? I'd like to summarize some of the more exciting developments around 3 themes. First of all, what evidence is there that mental health is getting onto the global health and development agenda? What are the new initiatives that are seeking to build capacity and new evidence? And how can we build global networks to change the minds and hearts of people about mental illness? I've chosen just one of many different references to the issue of global mental health that have appeared in the last 2 years. I've chosen this one, not least because the person making this statement is an extremely influential figure in global development, the UN Secretary General. And I think it's important to look at the second bullet point here in his statement, where he talks about scaling up services for people with mental illness being a good economic investment, an argument that we've struggled to make with ministries of health and with donors for decades. And another very important point that he makes, that it is also a pro-poor strategy, and another argument that we've struggled to make, as many people have often thought that mental illness is a problem of rich countries or of richer people in poor countries. We can now see evidence of very exciting new programs. I won't say much about MHGAP because I'm sure Shekhar will talk a lot more about it. And new academic initiatives, which are reflected in the launch in my institution in London of this new Centre for Global Mental Health. New resources being committed to mental health research just in the last 2 months. Here are 3 examples from Europe of major new calls for applications and substantial sums of money being parked behind this as well. And not very far from where I speak right now, just a few weeks ago, the director of the National Institute of Mental Health in his blog, I'm sorry the blog can't be seen very clearly, but I'm sure you can go to his website, he put this particular blog, Disorders Without Borders, which I think is very sweet. And it really reflects the fact that mental disorders don't know any borders, and that we should be doing something for mental health from the US funding perspective outside the US. One such example of such an investment is the Grand Challenges in Global Mental Health. I suspect most of you will know about the history of the Grand Challenges, first launched by the Bill and Melinda Gates Foundation about 5 or 6 years ago, which then became the basis of their funding plans. This is the 3rd Grand Challenge, the second one being on chronic diseases. And this one is focusing on global mental health, which will release its findings at the end of this year. And what's really important about this Grand Challenge is, of course, that it's backed by 2 of the world's biggest funders, the National Institute of Mental Health and the Global Alliance for Chronic Diseases. So this is not a researcher's Grand Challenge, but in fact it's a funder's Grand Challenge. And the challenges will then be backed by resources. What might be some of those research priorities in global mental health? Well, as part of the Lancet series, we actually carried out a priority setting exercise that examined, within the context of closing the treatment gap, what might be the sorts of research questions that we should fund. Well, not surprisingly, the major priorities was research that was looking at the development and evaluation for interventions for people with mental disorders to be delivered by non-specialist professionals. And then secondly, how to actually scale these up within routine healthcare settings. Here is an example of such a trial that is seeking to do at least the first part of the research questions. It's the large MANUS trial that I've led and which has just only recently been unblinded. And what I'd like to draw your attention, this is a trial of an approach to lay health workers treating depression in primary health centers. There were 24 primary health centers involved and just under 3,000 patients with depression randomized in these 24 centers. And what I'd like to draw your attention to is this particular photograph showing the lay health worker from the village where the health center is based. And this lady here is a psychiatrist who visits once a month each health center. And part of this model is a collaborative model, because a lay health worker performs best when she's being supported and supervised by a specialist. And this is an example of how one task shifts so that one makes a more efficient use of specialist healthcare time. The specialist spending more time building capacity, supervising, rather than directly seeing people. But I'd like to suggest that we need to go beyond implementation research in global mental health. Let us think about the fact that we actually don't know that much about mental illness. We need to acknowledge amongst ourselves in the safe room, there are no New York Times correspondents here, I hope, that actually we don't know very much about the causes of mental illnesses, and our treatments, let's be perfectly honest, aren't also all that effective. And I think one reason we haven't really understood some of the possibilities of what causes and treats mental illness is because almost all our research on etiology and treatment derives from only 10% of the world's population, which arguably share very similar socio-cultural and genomic environments. I would suggest to you that by researching mental disorders across cultures, we can actually advance our very knowledge about the causes and expand, in fact, our armamentarium of the treatments of mental disorders. Let us be inspired by this humble herb. This humble herb that's been known to Chinese emperors going back to 200 BC. Some of you on infectious disease would immediately recognize this herb. This herb was miraculously rediscovered about 30 years ago and is now the frontline drug for malaria. It's artemisinin. Perhaps there is a prospect here of studying the rich traditional pharmacopoeias for mental disorders that exist in virtually every culture of the world, but till today remain completely unmapped or undescribed or unevaluated. So it seems to me the mission for global mental health research is to generate local solutions which can have global lessons, and in doing so advance not just the mental health systems of developing countries, but indeed advance science as well. And lastly, I want to end by thinking about the actions we might take to change minds and hearts, because I don't believe that science alone can change minds and hearts. I'd like us to think about a health condition which is associated with great suffering, it's associated with great levels of stigma and human rights abuses, which despite the availability of treatments, the vast majority of people don't actually receive these treatments. And then imagine that step by step, everyone with this condition receives the care that we know they should have received. Of course, I think all of you will know exactly which condition I'm talking about. I think this is possibly the greatest global health success story of my time anyway. The availability of free treatment for people living with HIV/AIDS around the world. What an amazing story. I can still remember being in medical school and studying epidemiology in Zimbabwe when people with HIV/AIDS died by the hundreds in the wards of the medical college hospital. We were told at that time that we could neither afford those drugs nor did we have the necessary capacity to deliver them. Those were the stories that were peddled by drug companies, by donors, and indeed even by governments. But the TAC, the Treatment Action Campaign that started in Johannesburg in 1998, challenged these arguments by starting with 4 foundations. First of all, the evidence of effective treatments, the evidence that you do not need highly expensive HIV/AIDS units to deliver these treatments, the fact that you could shame drug companies into reducing the prices for their drugs, and by arguing that this was a fundamental human right. And I would suggest to you that these are exactly the arguments that apply for mental health. Look at the success story. I don't need to repeat it. Everyone here in the room is fully aware of where HIV/AIDS care has gotten. This is exactly the kind of inspiration that drew many of us who were involved with the Lancet series for global mental health. We realized that a bunch of 6 articles is unlikely to have much impact. We needed to think of a follow-up action. And inspired by the TAC and the global HIV movement, launched this movement for global mental health on October the 10th, 2008. The goal was to establish a movement of individuals and institutions in particular, and this is a very important part of the HIV movement, of course, the leadership, not just by scientists, but indeed, much more importantly, people living with HIV. And we think that it is time now for professionals to work collaboratively and together with equal rights of people affected by mental disorders on a common platform, to carry out actions to scale up services for people with mental disorders and promote their human rights. This is the latest membership of the movement, which consists of more than 1,000 individual members. As you can see, these boxes here represent the percentages of individual members. About nearly just under half come from developing regions, but more importantly for me, more than a third are people who are directly affected by mental illness. And these are the dots here represent the institutions, ranging from universities to journals to user groups to media houses who have signed up. And as Judith said, I would strongly urge you to go to the website here and sign up and become a member. Some of the activities that the movement is trying to use, as it's a completely voluntary movement, it doesn't have a bank account, it doesn't have a secretary, it doesn't have a chairman, is basically through volunteerism and through collaboration between partners, doing this sort of stuff, holding biennial summits that bring people together, a capacity building atlas that a colleague from the University of Toronto has designed, and most recently, a new series for the Lancet Medical Journal to be published next year to look at an update of where mental health services and action has gotten in collaboration with the movement. Here's the website, and you might want to also mark out the date for the second summit in October 2011 in Cape Town. So I'll finish off by suggesting to you that I am very optimistic. After having been in this field for 15 years, I can't even believe the kinds of resources that are being now parked behind global mental health. Changes in public health really need 3 core elements: a knowledge base, the strategies to implement what we know, and the political will to carry these out. I'd suggest to you that actually we already have a substantial knowledge base, and there have been many efforts starting all the way back from the World Mental Health Report, but culminating in the recent sets of evidence I've mentioned here that have synthesized this knowledge and some of the strategies. The movement of global mental health, the grand challenges for global mental health, just 2 examples of new initiatives that are seeking to use this evidence to create a momentum to radically transform the lives of people with these disorders. And my last slide, For me, the field has two futures, an immediate future and a longer-term future. The immediate future, it seems to me, is a very clear one. The scaling up of services through a task-shifting model and the comprehensive development of evidence-based primary care and community care services, combined with strengthening the human rights framework for people with mental disorders. This is a moral, ethical, and scientific imperative. But if I had a lot of money in my pocket and I had a crystal ball looking way into the future, I'd suggest to you that global mental health is the future of psychiatry itself. It is only by researching mental illness and its treatments in different parts of the world will we actually understand why people suffer these conditions, and will we discover new ideas on how we can treat them, thereby improving the outcomes of people with these conditions in all countries. For me, it seems to me that is the ultimate goal of global mental health. Thank you.
Okay. First, I'd like to start by thanking Judy and the Center for International Mental Health for inviting me. I'm very excited to be here today. That was a very difficult act to follow. I'm sure you'll all agree with me. But now we're going to change focus a little bit, and I'm going to talk about how we got mental health into the health policy of Uganda. And this is going to be more about policy than about anything else. I'm going to talk about what determines how priorities are selected, and Vikram has made my work a lot easier. And then I'll talk a little bit about the context of Uganda in about 1996, when we began the process of integrating mental health into the health policy. I'll provide the chronology of the development of the mental health program, and then I'll provide the policy analysis and finish off with some recommendations of how this could be applied, whether at national level or global level. I think the big challenge we have is how to get mental health better positioned within the global health agenda or global development agenda as a whole. So what is it that determines policy change? Is it the global burden of disease? I think we started in 1993 very optimistically when the World Development Report came out, and for the first time we got a measure of the burden of mental disorders, and we felt, well, this is going to do it. We're going to finally get some attention on mental health. And 1996, the data from the World Development Report was actually published, and this has continued through the years as Vikram showed. But as we know, in 2000, when the Millennium Development Goals were being determined, mental health did not make it there. And this has been a this has been a big challenge, because for most governments, when they have to determine where it is the funding goes, and for most developing country governments, this is usually determined by where donor funding is going to go. It is made on the decision of the Millennium Development Goals. So that seems not to have worked. So then, is it the evidence of cost effectiveness? Because in about 2000, we were told, well, if you don't have evidence for cost effectiveness, it's very difficult for us to determine what it is we should be doing. We recognize that it's a big burden disorder, but if you don't have any evidence that something can be done about it and that it is cost effective, then we really can't do too much. So in 2001, the Commission on Macroeconomics and Health had a subsection on mental health, and they did provide the evidence. And in 2006, the disease control priorities also came out with further evidence. And there is evidence now for cost effectiveness of mental health interventions for all regions of the world. And for anybody with an interest, you can look up the 2006 Disease Control Priorities Project. However, we still have a problem getting mental health on the global health agenda or the global development agenda. So what I hope to do is to use the Uganda case study to sort of provide an example of what can be done, because in Uganda we didn't have any epidemiological data, neither did we have the cost effectiveness data, but we were able to put mental health into the the health policy and the health sector strategic plan. In about 1996, Uganda was just coming, well, it had been 10 years since we came out of 15 years of internal strife. I'm sure you all know when Amin took over in 71, and then everything sort of went downhill from there, till he was kicked out in about 1979, and then we had 5 years of very difficult years when there was conflict almost every other day. Even in the city, you'd go into work and then have to run home because violence had broken out. And in 1996, the NRM government, that's the present government that we have in power today, came into power, and we started with some stability. So 10 years since then, in about 1996, is when I was posted to the Ministry of Health as the National Mental Health Coordinator. So we still had violence in the northern part of the country, and this has made it quite a bit in the news. I'm sure you know what has been going on there for the following 20 years after that. However, for the rest of the country, it was, for the big part, very peaceful. In 1996, the population was about 21 million people, 85% in rural areas. It was a very poor country. The GDP was about $280 US. We were number 165 on the poverty index. Per capita expenditure on health was about $12 US. So you can imagine how far that would go. And of this, only about $4 US was actually public funds. The rest of it was donor funds or out-of-pocket expenditures. And health service coverage was only 45% of households. The health indicators were also very poor. Some put the life expectancy at about 45 or 50 years for males and females, and others actually put it at 42 years. And you can see the infant mortality rate there, the total fertility rate. We had a very high maternal mortality rate. The HIV prevalence was still quite high, and the mother-to-child transmission of HIV/AIDS was also quite high. And a burden of disease study was carried out about then, and they looked only at mortality, and they found that 75% of life years lost to premature mortality were due to 10 preventable disorders. So the policy analysis question would be, with these high levels of poverty, a very constrained health budget, and a huge burden of preventable mortality, how did mental health get into the Uganda minimum health care package in the health policy and in the health sector strategic plan? So I'll first begin by presenting how the mental health services developed, and then I'll get into the policy analysis. Mental health services in Uganda developed like in most other countries of the world. Essentially, we were maybe just a little step behind. In the 1920s, when the British started getting into Uganda, at that time, I think the science was to build asylums, because we didn't really know what to do with people with mental disorders. And so an asylum was built in Masindi, which is about 100 miles from Kampala. In 1935, the Mental Treatment Ordinance was passed, and this stayed in effect until about 1964. In the 1950s, as the medical services were being developed, and as the science improved on the treatment of people with mental disorders, the unit in Masindi was moved to Kampala at Mulago Hospital, where we actually now have the National Referral Hospital. And at around the same time, they also built Butabika Hospital, which is the big psychiatric hospital. It had 900 beds, which is really huge for Uganda. And it was a long-stay institution, so it was the sort of place as you can imagine how these units were back then, with big wards and people staying forever almost. Once you got in, it was very difficult to get out. But at that time, it was thought to be a state-of-the-art hospital south of the Sahara, north of South Africa. In the 1960s, holding units were also built all over the country, because the one treatment center was Butavika Hospital or Mulago Hospital. And so since the psychiatrists were very few, the only thing they could do with the patients who were up country was to put them into holding units that were built adjacent to the hospitals, and where they kept them until they could organize transport to move them to Butavika or to Mulago. In 1964, the Mental Health Act was passed, which is still in effect today. We're just working to revise that one. In 1971 was the coup d'etat, where Amin took over and we had the gradual decline of services. 1986, NRM came into power, and then 1996, the position of National Mental Health Coordinator was created. Since 1996, every single year, Uganda has celebrated World Mental Health Day. And this is going to be important as we discuss the policy analysis. For this first World Mental Health Day, the First Lady of Uganda, the President's wife, was the guest of honor. And this ceremony was actually held at Butavika Hospital, and there was a lot of resistance for her to come to Butavika Hospital, because the way that laws are set up, if anybody goes into a psychiatric hospital, it means they must have a psychiatric disorder, and therefore her advisors advised her not to go there because it would reflect badly on her. But she decided to ignore their advice, and she came to the celebration. And that year we also had the first meeting of district mental health coordinators. So each district had a person who coordinated the mental health services in the district. And since then we have had these meetings every year. They are supported by WHO. In about 1997-98, the sector-wide approach was introduced in Uganda. And as you know, the sector-wide approach is something that sort of says the country is now in the driver's seat, and the funding is going to go into a basket rather than project funds as they were before. And it was because of the introduction of the sector-wide approach that it was determined that health policy had to be formulated, because the health policy was going to help in contributing to achievement of the Poverty Eradication Action Plan, which was the development plan for the whole country. And what was written in the health policy is what would be focused on and what would be funded by the different resources that were available. So in doing the analysis, I'm going to use a two-lens approach. The two lens, one is the punctuated equilibrium, which uses the theory that to get something into policy, you have things going on very slowly, but very quietly, and then something happens, what is called a friction, and this eventually leads to the policy change. The other theory is the multiple streams theory, and this one uses three streams: problems, policies, and politics. And these three streams may be moving along independently until a policy entrepreneur comes along, and this person then identifies how the three are going on, and then working or manipulating the system, or identifying a policy window opportunity. They then cause the three to interact, to come together, and then you get the policy change happening. And of course, within any policy analysis, there's the issue of power. And Uganda is a very bureaucratic society, and there's a lot of authoritarian power, which is invested in individuals. At that time, we had just had a director general who was newly appointed. In the Ministry of Health, previous to this, we just had the permanent secretary, who is the signatory on behalf of the government. But it had been decided to have a director general who had almost equal power to the permanent secretary. But his preserve was more the health policy decision-making side of things. And according to the policy theorists, they say that there's a probability that an actor within a social relationship would be in a position to carry out his will despite opposition to it. And if there's some opposition to somebody who believes or who has this feeling about big authoritarian power, then this can be a strategic opportunity. And this, I believe, is one of the things that happened in the case of Uganda, where you see that quote made by the Director General. It isn't specific to mental health, but it sort of gives you the essence of the sort of person that he is. He went on to become, I believe, Assistant Director General at WHO, but he was somebody who felt very proud to be an African, and he felt that any time there was resistance to decisions he was making, that was against him as an individual. And some of the resistance that he was getting was trying to get pushed into making decisions that he didn't quite agree with. And so in order to demonstrate his power, he sided with the decision to integrate mental health into health policy. Stakeholder analysis is another aspect of policy analysis, and those are some of the questions that are often asked. Who are important? What do they know about the policy? What position have they taken? What do they perceive to be advantages and disadvantages, and which ones might form alliances? So if we look at the Uganda stakeholder analysis, there are the three: those who supported, those who were neutral, and those who opposed. And one of those who was neutral but more moving towards support was Danida. And Danida was one of the big funders to the health sector. And of course, WHO was supporting us very strongly. At that time, or soon after that, is when Gro Harlem Brundtland came into WHO as the Director General. And some of you may recall, in her inauguration speech, she included mental health as the third of her priorities. So WHO felt the need to support mental health as a result of that. And the WHO office in Uganda was very supportive. The other donor was the African Development Bank. They had funding that they had identified, and they wanted it to go into mental health. And if we did not have mental health as a priority, because of this sector-wide approach and the basket funding, then we would lose this money. And so it was good to have them. The Director General of the Ministry of Health, I mentioned him already. The director of Butabika Hospital, as I said, is the big hospital, 900 beds. He was supportive because the money that was going to come out of the African Development Bank was going to do a lot of rehabilitation at the hospital. That meant resources coming to him. But he was also, being a director, he sat on the high-level meetings of the Ministry of Health, and therefore he too had a big influence in the decision-making. And then the mental health NGOs. At the time that I got into the Ministry of Health, we didn't really have very many mental health NGOs, but 3 of them were created. That's okay. But 3 of them was created. One was Mental Health Uganda, the Epilepsy Support Organization in Uganda. Mental health, epilepsy, they interact, and Uganda Parents of Children with Mental Disabilities. These were all supported by Danida funding that came through SIND, the mental health NGO in Denmark. And they were very, very supportive, because every World Mental Health Day, we had a lot of activities, lots of things happening in the newspapers, marches through the streets, and articles. And so this made it apparent that there was a lot of support from the bottom, and something that the government could not quite ignore. The Ministry of Finance is colored neutral, but they were actually more in the opposed because they felt that investing in mental health was not going to provide a return to that investment. But being that they were government of Uganda, they felt that they should support what the Director General was recommending. Unfortunately, the World Bank was not very supportive because their approach was that Uganda should focus on those disorders that are preventable. And if the evidence was 75% of the burden was preventable disorders, then that is where the focus of the government should be to have the biggest impact. I have here the Commissioner for Planning in the Ministry of Health. He too was probably not very supportive because his thinking was more in line with the World Bank. He used the priority setting approach using the burden of disease study that looked only at mortality and did not even measure mental disorders. But because he was in the Ministry of Health, he also had to toe the line of the Director General. And then, of course, there was a Ministry of Health programs that saw mental health as competing with the limited resources within the Ministry of Health. And so they most likely would have opposed, but because of the Director General, they felt they had to support. So when we come to the process, in the punctuated equilibrium theory, there's a role where in order to change, you have to change the thinking of individuals. And individuals, the change in their thinking, according to this theory, is how they interpret the context. And they propose that some of this change can be carried out by manipulation of information. In Uganda, what we did was to have, because we didn't have any data on epidemiology, so what we did was to use what we knew as international baseline data. If about 1% of the population has maybe psychotic disorder, we translated that into data for Uganda using the population we had, and that's what was published in the media. So this was obviously manipulation of data, but it did have an effect, but it caused people to it caused people to have a very big worry. If you know that maybe 5% of the population may have a depression at any one time, and you convert that into actual numbers, 500,000 people have this, and it comes out as a big newspaper headline, usually around World Mental Health Day. It had the effect that we wanted. And maybe this is unethical, but maybe not, because it had the effect that we wanted. The multiple streams theory has individuals as well in the process. The individual is the individual policy entrepreneur, who is not a mere advocate, but they are power brokers and manipulators, and they're usually people who are persistent. They also have to be skilled at coupling, and they're also able to attach problems to solutions. So it's not just about being a good advocate, but you also have to be able to have solutions. Collective action is very important in the punctuated equilibrium theory, although it is not mentioned very much in the multiple streams. And these are the mass mobilizations that I told you were carried out usually around World Mental Health Day. We had a lot of that, and it was also very morale building for the mental health workers. They felt for the first time we can also do something. For the first time we can also go out and feel proud of what we do. Because very often the stigma that is attached to the disorder is also attached to the people with the disorder. And the idea that they could also go out and they got onto TV and they did all kinds of drama, and this, I think, was also part of the collective action of the interest groups. The institution is important in multiple streams. In order to have a policy change, within the political stream, the National Mood Pressure Group campaigns and administrative and legislative issues are discussed. But I think the most important thing here was the positioning of the policy entrepreneur in an institution, because being within the institution, you're aware of the opportunities that as they come up, the opportunities that come up as they come up. So having somebody in the Ministry of Health, as the health policy was being thought about and being developed, was important, because then you're able to be there and to talk to the different people that have to be talked to and to make the case for mental health. So that the policy change in the punctuated equilibrium, we had the small progress. It's not that since 1920 or the 1950s, nothing had happened until 96. Things were going on all along, because we continued to have psychiatrists trained, we continued to have services provided, but it was in 1996 that some major change actually happened. The friction that led to the major change in 1996 may not be very clear. It could have been the external factors, it could have been the pressure from WHO or the African Development Bank. So it could have been internal factors like the introduction of the sector-wide approach and the development of the health policy, or it could have been that enough pressure built up, all these things coming together, and this is what probably led to the policy change. In the multiple streams, as I mentioned earlier, we have the policy entrepreneur, we had the policy, which was the health policy being written up. There were politics, because if you have somebody like Gro Harlem Brundtland and she makes a statement that includes mental health, I think the people below her are going to follow up on that. They're not, I mean, everybody wants to be seen to be doing what she says she's going to achieve in her term of office. But there was also politics in that the African Development Bank had money for mental health, and if mental health was not prioritized, then Uganda would have lost that money. So this was a political decision on Uganda's part to say, yes, we shall include mental health. Mental health was included, and we got 0.8% of the health budget. And as you can recall, the health budget was $12 US, so 0.8 of that per capita is not a lot of money. But because we got that 0.8%, we were able to get the African Development Bank funding, and mental health is now 4% of the health budget, one of the highest in sub-Saharan Africa. So what can we learn from this case study? Even without data demonstrating a huge burden or evidence for cost effectiveness, mental health can be prioritized. So it's not saying that we should not focus on building up the evidence for the epidemiological burden or for cost effectiveness, but I think we also need to take into account how the policy process works and take that into account as we think about how to get mental health into policy agendas. The other is the importance of analysis of the policy process in order to understand what can be applied elsewhere. I think we tend not to look too much into that. We tend to look into what a country is doing, what is the burden, or what are the services, or what are the numbers of human resources, but we don't look at what is the process of actually getting mental health into the policy. And then strengthening of mental health policy analysis, even as we build the evidence on epidemiology and cost effectiveness. I think this is one of our weaknesses. We don't really have the mental health policy analysis, especially whether at national or even at the global level. Thank you.
Since we're running a little bit ahead of schedule, which is very exciting, I wanted to, before we take the break, take an opportunity if anyone had any questions about clarification or any specific questions for our first two speakers. And if so, go to the microphones just for clarification questions. And if not, where's the break? There's time. So what I'd like to do, invite you now is to take a brief break. So we'll take about, what time is it? It's 2:20 now, so 2:40. So about a 15, 20-minute break. I would invite you to, there are some refreshments outside, and then we'll come back and we'll continue with the conversation. So I hope you enjoyed the refreshment break. And to keep us somewhat on schedule, I'd like to now invite Dr. Martin Knapp to come up and start talking about how economics influences the case for mental health on the world stage. Thank you.
Okay, thank you very much indeed. I'm delighted to be here. Thank you very much to the Department of Mental Health for inviting me, and particularly to Judy for well, inviting me and showing unbelievable patience. Some of you will know that 24 hours before I flew out from London, I still didn't have a passport, let alone a visa into the US. But Judy was calm throughout, I think, so her emails suggested that, so apologies for that. But I'm delighted to be here. I did spend 4 months at Hopkins in 1989, and haven't been back as often as I would have liked in between times, but I did, in special preparation for today, watch a few episodes of The Wire, and just to remind myself of what you're all like. So you just look like you do on television, really. That's okay. So I want to talk then about how economics influences the case for mental health on the world stage. And just perhaps a bit of background. I mean, you got the little bio at the beginning from Judy introducing the speakers. A little bit more background, which I think helps to understand the sort of interplay between economics and some of the other perspectives and concerns that we will want to bring to this discussion. And I can illustrate that by just describing the main two places I work, London School of Economics and King's College London. And those are two different environments in which I do quite similar work with quite sometimes different perspectives. The London School of Economics is a university. It is a social science only university. And the work we do there in the mental health field is, as you would imagine, very much focused on the policy. And so we're concerned with the policy relevance and the policy about mental health. At the other institution, King's College London, it's a medical school. The focus then of economics work and health services research more generally would clearly be, well, not clearly, but tends to be more on the practice. And I think one of the big issues we face when we're thinking about the development, the growth, the improvement of the quality of mental health is this interplay between policy and practice. Because any practice developments are going to be influenced, as Florence was illustrating just now, by the wider policy context. But policy itself can't go forward unless it's got confidence that the practice developments, the practice excellence is there on which to provide a baseline on which to build sensible policy. So I want to then look at some of those economic questions, and I'm going to structure my presentation through these headings very quickly about why economics, where does economics interface with the other things we've been hearing, and then to look at some of the arguments for making a case. Now, if I reflect back, I've been working in the mental health field. Well, I mean, I wasn't actually working in mental health when I came to Hopkins in '89, but I did meet some very influential, some very good people there, and started working in mental health area soon after I returned to the UK. But at that time, late 80s, early 90s, economics didn't have much influence on mental health policy and practice. Nothing like the influence it does have today in many of those high-income countries. So I want to just reflect on what is it that allows economics to have an impact. Where does it have an impact? And then to see what the consequences for that would be, or what the implications of that would be when we think about the wider world stage, particularly in low-income countries. So that'll take me through sections 2, 3, 4. Then section 5, what stops that case being made, and then a couple of slides just to summarize us. Now, I'm going to try and keep a watch on the clock. The light is just in the wrong position, but please do tell me when I talk too much. Okay, so why economics? I'm going to show you what is titled A Simplified Mental Health System. It doesn't look very simple, but it is incredibly simplified. And the reason for putting this up here, I mean, this is a system which, let me get this to work. No, okay, battery's gone. This is a system that, let's do it with the pointer. It starts over here with revenue collection. Doesn't matter where you start, but probably me. Starts over here with revenue collection, getting the money together, getting the resources together, which would support, in this case, a health or mental health system, and then working its way through different boxes, which I'll describe very briefly, to achieve something which is very boringly labelled here, but final outcomes or outcomes. You know, the improvements in the health, the quality of life, the functioning, the circumstances of people with a particularly identified and measured, assessed set of circumstances or needs. Now, what that system can do, okay, it wasn't the tool, it was the me, but there we go. What this system can tell us then, if we go from these resources here through, the resources get given to some purchasers, some commissioners. They then commission services, maybe from different agents, depending on the type of the system. Those agents employ resources, and as Vikram emphasised earlier, the key resource in mental health, of course, is the human resource, the staff, but also they need to work in buildings, they need to work with materials, they may need medications, and so on. Those resources together produce something I've called intermediate outputs, again a very boring term, but it's the services that people will get to see and get to use, services of particular quality and a mix of different patients or clients or users, consumers. And those services are what, in combination with something else, produce these outcomes. Now, the something else is, again, horribly labelled block of things called non-resource inputs. They're things like the social environment, the attitudes of staff, the resilience of the individual patient or family. Those are factors which will clearly have an influence on how successful the system is in improving health and quality of life, but they don't have a readily identifiable cost or price. So you can advertise on the web or in newspapers for 3 trained psychotherapists. You don't usually advertise for 3 supportive social environments, okay? But we know that skilled staff can create those things. Now, this simplified system misses out a whole range of other things that are important, things that you'll be studying, things that you'll know about. But it helps to illustrate, I think, the economic issues here, because we have to think about, are we generating enough resources in the first place? Are those resources being fed through to the right budgets, to access the right, or to employ the right resources, to deliver the right services, to achieve the right outcomes at the levels that we would want to achieve? Now, in this context then, it's very easy to see why we need economics. Why don't we just get loads and loads of these outcomes? What's stopping us doing that? What stops us is the fact that we have scarcity. We don't have enough resources. This is Economics 101, slide 1, okay? This is where we start. We don't have enough resources. If we had enough resources, we wouldn't have to worry about anything we're talking about today. There are never enough resources. It's not to do with the fact that the world is going through a recession, or that some countries are facing difficult times, or that some countries don't allocate enough resources to mental health. It's a pervasive macro scarcity of resources. We are never going to have enough resources to meet all the needs of mental health. We're never going to have enough resources to meet all of the wants or preferences of individuals in the world. So that scarcity is the starting point for economics. And it leads then to requirements, needs for society to choose how to use those resources. And then choose is a very polite word. Ration is a dirty word, okay? Politicians never use the word ration, but that's what they do. They ration. They have to use a lot of skills, honestly, to choose how to allocate those resources. So we have to find some way of doing that. And what economics is about is looking for ways to make those choices more efficient and more equitable, fairer. Those are the two main criteria that economics would be concerned with. So that's the starting point. And what we then can identify that decision makers need to know when they're making their decisions, let's say in the mental health system, there's a whole range of things there, a lot on that slide. But the decision makers want to know, obviously, what people need, so they need to have some understanding of those needs. And over time, in the mental health system, we've begun to realise that perhaps it's quite useful to also know what people want, not just what we think they want. So they need to have that information. They need to know who those people are, their characteristics, their circumstances, etc. They need to know what services, treatments are available or could be made available to begin to meet those needs, to satisfy those wants, what staff and other resources deliver those services, how much it costs to employ those resources, where the funding comes, and then what outcomes will be achieved. That's just a repeat of the previous, or the slide but one. But central to that process, I would say, not dominant, and not the only thing that is central, but in there is a lot of economic stuff. Resources, costs, budgets, that all of those things are necessary to deliver mental health. And I don't know whether Shekhar will say it now, but he did in the lunch discussion. I've heard him say it before. Health systems are not about making money, they're about making health or improving health. But we need the resources in there somewhere to deliver the services to achieve those health objectives. So the question then is, how do we use economics to make a case? And I'm going to just give one or two illustrations from high-income countries and then pick out why that doesn't necessarily transfer very easily at all to a low-income context, and what are the transferable arguments. So making a case, and I think there are kind of 5 bits of the case that economists like me have used, or that decision makers use information that we generate to make a case for improving access to mental health services, improving access to mental health for the population in a number of countries. Now this is purely hypothetical, and I did agonise whether in break I should get rid of the numbers just to stop distract. 10,000, it could be anything, 10,000 whatever you likes, okay. It's just hypothetical column, and I want to just to put it there, and I'm going to put other columns in there later on. That sometimes the economic case is saying, well, the overall cost impact of, say, untreated depression is enormous, open brackets, scandalous. And surely something needs to be done to reduce that cost, that is, to reduce the suffering and impact that is implied there. Now, this is the sort of economic argument that certainly in the UK and some other countries I'm familiar with, you're seeing being made more and more. Here's an example. Dementia costs the UK 28 billion each year. This is a headline from a national newspaper that made my mother very happy because it got me onto national television. She could tell all her friends. But we did a study which had lots of things. We looked at the prevalence of dementia. We looked at how the prevalence will change over time. We looked at the system for supporting people with dementia. We looked at the evidence base for improving that system. And we also looked at the overall cost of dementia. What did the media focus upon? The overall cost. £28 billion, whatever that is in dollars today, $25 billion say. But that number fits neatly into a headline. A headline doesn't easily contain the expression, dementia is terribly disturbing if you've got the illness and very burdensome if you're a carer and can shorten your life and whatever else, okay? But that's what that 28 billion is summarising. So one case that can be made for mental health, even though it's alarmist and usually, as in that case, pretty dreadful science, I mean, this was a really, it's just a very crude calculation. This was not in any way the main thing we're trying to do, but that helps to draw attention to the case. And so many people, many agencies, many advocacy bodies, indeed many pharmaceutical companies, will try and generate this information to draw attention to the enormity of a condition and its impact on society, in this case through its financial impact. So in a high-income country, these so-called cost of illness studies are, as I say, becoming increasingly common. They're usually fairly straightforward to do. The costs are usually readily identifiable, and they stack up quite quickly. In that dementia case, what we did was look at the cost of the services, the healthcare services, the social care services that people with dementia would be using. We looked at the impact on families and how many hours of unpaid care they provided and attached a cost to that. If it was looking at a younger age group, you would look at how many days of work people lost because of their illness. You might look at the impact on criminal justice if people, through their behavioural problems, are more likely to commit crimes or be in contact with services, etc. So these are things which are all readily identifiable, usually, and you can add them up, and then lobbyists of various kinds will use the numbers to great effect. And the media, as I say, love the sound bites. So big costs grab attention. They say do something, even if they don't actually tell you what to do. And these are not, I have to emphasise, this is not in any way evaluative research. This is simply descriptive, attention-grabbing research. And if you're going to do something about, let's say, dementia, some way of improving the lives of people with dementia or their families, that sort of study is not going to help you at all. You need studies which look at the effectiveness and cost effectiveness, etc., of different treatment modalities, for example. Now, what about a low-income country? And is this going to work? Is this kind of strategy going to work to make the case for mental health? Well, it's going to be much tougher. For a start, most of the costs are hidden. Many of the costs which we identify quite easily in a high-income country are there because the responsibility for providing the care and support has been transferred from the family and community into a collective agency, a charity, a non-profit body, a government. So we've got then some formalised structure around it because those agencies employ staff, and we can then begin to add up the money. Whereas if your services and support and treatment is provided by family members or is delivered through a system of barter or through charity and just altruistic support, pretty difficult to begin to calculate what those costs are. And when you do find them and add them up, they don't amount to anything very much because provision, whether it's formal or informal provision, is so low, as we've just been hearing before the break. In addition, I suspect there are fewer groups around to take up the cause. The US has got many more lobbying groups than we have in the UK, but the UK does pretty well when it comes to mental health, and every main mental health disorder has got its own national group, and they try and grab as much media attention as they can to get more resources pumped into their area. Well, that's pretty tough in a country where you haven't got these sort of lobbying groups or the system to allow that lobbying to happen. And anyway, there are many other causes competing for attention. So this very crude, but actually sometimes quite effective way of using economics to grab attention works in some country contexts, but I think is much tougher where the costs are more hidden and anyway are much lower in the first place. Now, the related economic argument, and the second way of making the economic case, is actually to break that cost down. I've already been doing it implicitly already. To say, okay, 28 billion for dementia or whatever it is for another disorder or condition or need, let's look at the elements of that and use the information on those elements maybe to try and exert some influence. So the challenge then, the cost implication, the cost burden, if you like, is complicated. When that total cost is broken down, it is clearly affecting many parts of society with different budgets, with unwanted impacts. For example, depression is the single most common reason for work absenteeism in the UK and many other countries. Now, I have a colleague at LSE, a retired professor, a very eminent economist, who is now a Lord. He's Lord Layard in the House of Lords. He knew nothing about mental health all his career, and then wrote a book on happiness, a very good book on happiness, called Happiness. And as an economist, he knew that the biggest driver of happiness was income. But all his research for the book showed that it wasn't income, it was actually mental health. And he got interested in this area, and he and I and David Clark, who does a lot of cognitive behavioural therapy at the Institute of Psychiatry, did some analysis which showed how just very simple treatments for depression would save the health service money, but would save much, much more money to the part of government which funded social security, that supported people who were out of work. And that other part of government then said, We need to do something about that. It wasn't making a case to the health department as such, it was making a case to the Department for Work and Pensions, who had to carry that big burden of work absenteeism. Now, that again is about using this evidence. It's not evaluative evidence, a little bit more evaluative than the previous one, but it's using the evidence to say, hey, mental health is unusual in the health spectrum for having these very wide spillover effects into many other parts of society. It affects the criminal justice system, the social security system, the employment area. It affects families, it affects lots and lots of things. Let's understand what those impacts are, maybe in money terms, that's one way of doing it, and then use that evidence to help to make a case. We know that severe mental illness imposes catastrophic costs on families in low-income settings. So recognise the impact not just in the health domain, but the impact elsewhere. In that second example there, recognise that trying to do something with out-of-pocket expenses to address a mental health need in a family can be, to use the technical term, catastrophic in terms of the proportion of income that will be used up. Now, 3 examples, just very quickly, which illustrate the challenge and how we overcome it in high-income countries and how it's hard to overcome it in low-income contexts. This is a very simple pie chart of the costs of depression in England, and there are 2 bits that are shown on there at the moment. All the blue bits down the bottom are healthcare costs, so this is a big chunk of medication, which is the responsibility of primary care doctors primarily. This is the primary care doctor time as delivered, a bit of inpatient care, a bit of day care, which rounds down to 0, a bit of outpatient care. Now, those are dominated by the economic cost of premature mortality. Economists are lovely people and like to put a cost on those things. But you can see that already the healthcare cost, which is pretty substantial, I can tell you that, is smaller than the costs which can be implicitly attached to premature death. But if you remember this blue bit and this yellow bit, and I take them into the next slide, that's exactly the same yellow and blue bit, now completely swamped by this big red chunk of pie, which is the costs associated with lost productivity. People with depression who are not in jobs, or they're in jobs and they're absent because of their illness, because of their depressive illness. Now then, that tells us immediately the story I told you earlier about trying to do something about the non-health budget effects of depression, that if we're going to make a case for mental health, we might want to start to play on these other impacts. And in fact, down here, I put down a big missing element. There's another element, this wonderful US term, which we now use across the world, presenteeism. You're at work, but you're not very effective because of your health problem. And the estimates suggest that that's twice as large as the cost of absenteeism. So, yes, mental health has big impacts on health budgets, but it can have bigger impacts elsewhere. Here's a second example. Just take these builds out. This is a study from Seattle, Greg Simon and colleagues looking at people on one of their big databases. And they looked at depression and diabetes. And you can see here that these are the numbers are the number of self-reported complications with diabetes, and the 3 groups: patients, individuals with no depression, with subthreshold depression, and with major depression. And you can see that the effect of the diabetes complications is exaggerated, exacerbated by the severity of the depression. Now, this is again, and I should have said this with the previous example. With the previous example, we've changed our focus away from just the health consequences of depression to look at the wider consequences. This is a good example of a changing perspective in mental health research in many high-income country contexts, which is this recognition of the major economic consequences of comorbidity, something which was almost completely ignored until quite recently. This complication effect will be just as huge in any other part of the world. We just haven't got the evidence base to show it yet. A third example, this is about children with behavioural problems, a study by Mike Rutter, who's done loads of work in this area, following children through time into adulthood, and a group of us looked at one of his data sets. And what we did was to look at children who at age 10 were described in 3 ways. They had no mental health problems at all, no behavioural or emotional problems. They had conduct problems, or they had conduct disorder. Conduct disorder would be they reached the threshold for diagnosis, even though they probably didn't get diagnosed and treated at the time. Conduct problems were children who were behaviourally more behaviourally concerning, but didn't reach that threshold. So they were a bit of a nuisance to the teacher. Nuisance is probably the polite term that they would have used if they had more time to think about what they said in the questionnaire. But these were children who were difficult in the school. Now what we did was to look at the services that those people used between the ages of 10 and 28. And these are the additional services, not regular education or regular healthcare is there. So this is the special education, the green bit, and other little bits of service they used over that 18-year period. These are the children that didn't reach the threshold for diagnosis, but nevertheless had these behavioural difficulties. And this is the group of children with the conduct disorder. Now what you can see here over a 28-year period for what is almost certainly an untreated group, because back in early 70s when this group were 10 years old, there was very little around by way of effective treatment for conduct or behavioural problems in childhood. What you've got is a difference. These are children who are defined by their health problem, and there is a difference in the green bit of the pie in terms of the healthcare costs, but the big differences are elsewhere. Now the reason I put this slide up is because the interventions that could be delivered today for conduct disorder, and there are some very good interventions around today, they do have an impact immediately. Their economic impact is tiny immediately. Their economic impact is big over 28 years or 18 years or whatever else. And so part of the problem in making the economic case in this area is the problem that the benefits, the economic benefits, don't occur very quickly. They occur much further down the track. So what does that imply about a high-income country context then? We know that employers are concerned about productivity losses, about staff turnover and so on. Employers in many countries are the main source of health insurance payments, so they have a more direct impact than in countries like the UK, but nevertheless they're very concerned. Governments are concerned about the economic impact, people not able to work, not able to contribute to the economy. They're concerned about the welfare payments that they have to pay out. Governments also keep one eye on the longer term impacts, but governments have been willing to invest in interventions which have, yes, some short-term benefits, but their bigger benefits are over the life course. And that requires courage on a part of a government that's going to face re-election in 4 or 5 years, because they're going to spend money on things which won't show immediate payoffs. Patient groups can highlight the huge personal impacts for the people concerned, and others can point to poverty and social exclusion. So it's relatively easy to make the case for increased investment in treatment in those circumstances. And you can play, and what economists do, or what people do with economics information, is to play on those different impacts across different budgets. In a low-income context, the challenge is quite different. Not only do we have low levels of formal employment, which makes it hard to identify the productivity effects, because they're going to be felt not through some formal structure employment, but they'll be felt by the individual, by the family, by the local community, much, much harder to put some sort of value on. Not impossible, and it's been done, but it's much harder to put that value on, and much harder to use that, more importantly, as a lever to influence government or other big decision makers. There are few welfare payments anyway, so you're not saving much by taking people off welfare. There are very high rates of time discount, so decisions need to be are dominated by what's going to make an immediate impact, not going to make an impact in the longer term. Few active lobbying groups again. Poverty is a major issue, and so mental health's contribution to poverty is also a major issue, but mental health is generally, or has not until relatively recently, been seen as a key cause. So again, we have an economic case to make, but it's much harder to do it in a low-income context. Then there's 2 other economic cases that I can talk about. Can those costs be reduced or redistributed? Now again, go back to our hypothetical diagram. Can we find a way of cutting this cost from this level up here down to something here by applying this red bit. Red is meant to be treatment in some exciting way. But can we spend money on treatment, which is adding to the cost, but that treatment will bring down the overall economic impact of that need, that disorder, that condition. So can we find some way to prevent or treat, let's say, depression in a way that cuts those overall costs? We know, for example, that identifying psychosis early, detecting it early, and intervening early can reduce expensive inpatient admissions, and that will, within a year, will pay for itself. So early intervention services in many countries look expensive at first glance, but they usually pay for themselves very quickly because of their immediate impact on another part of the health budget. We know that individual placement and support can help people into employment, saving productivity losses and future healthcare costs. So what sort of economic arguments do we hear then? We also have this argument about redistributing the cost, and I'll come back to what we do about these savings in a moment. Can we find a way to prevent or treat that reduces one particular cost burden? For example, the costs falling on individuals or families and communities. So better dementia treatment will increase healthcare costs, usually, but would save the burden on families, the implicit or often real out-of-pocket costs. Identifying psychosis early would head off, we know, violent incidents and blighted lives. So we can see how that expenditure on treatment can also achieve an effective redistribution of those costs. So in a high-income country context, because the costs of responding to mental health are often so high, the potential for a preventive initiative to be cost-saving is pretty good. It's not always easy to get buy-in across sectors, but the case can be made. So cost-offsetting initiatives exist and are adopted in those cases, with, of course, benefits for the quality of life of the individuals. In a low-income country context, the challenge is much greater. If you're not spending much on mental health care in the first place, then it's hard to find initiatives that are cost-reducing. Not impossible, of course, but much harder. And anyway, given the huge underinvestment in mental health, cost reduction might not be the aim we want to be pursuing. And one of the concerns often is if you do begin to reduce cost, you release resources and they then leach out of the mental health system into other parts of healthcare or other parts of the economy. So there's a challenge with making that economic case as well. Not impossible, but there's a challenge. Okay, now the fifth one, and I have to speed up because I've got the 5-minute warning, and I apologise for talking too much, is about cost effectiveness. Can we use cost effectiveness arguments? And the issue here is that it may be that we spend money on treatment and the overall cost goes up, but there is still a case for doing it. And this is when economists stop being glorified accountants and start being real economists. Because economists are not interested in money. Economists are interested in money and its relationship to outcomes. And that's what cost effectiveness is trying to do. So the question then, is there a case for arguing that we should spend more on mental health because the consequences for health are worth it, are worth that investment? So we know that second-generation antipsychotics can increase spending, but many governments around the world believe they're worth buying because the outcomes are worth it. Not every government. Cognitive stimulation therapy for people with dementia, we know is effective, but it costs more money, but it's being rolled out, certainly in the UK, quite widely. So it's not that you have to save money, but you have to make a case for a better balance between between costs and health gains. So if the core clinical question is, does this treatment work? The core economic question is it worth it? It's not clever, it's not easy, it's not difficult to think of things which could improve people's health, but it is pretty difficult to think of things that improve health which are affordable. And that's the challenge. We have to face up to this is it worth it question. And the is it worth it question applies especially when an intervention is more effective but also more expensive, because we have to ask about that justification for those higher costs. So how is that cost effectiveness case made? Now let's go through these slides and then I think I'll draw to a finish then to save you time. There are 3 ways in which this is made. One is by getting decision makers to say what they are willing to pay, and a couple of illustrations there. Studies of a cost per depression-free day. We did a study that showed that computer-based CBT was more effective than face-to-face treatment, but cost more money. Face-to-face treatment without CBT, which was what was normally available. The additional cost per depression-free day was less than the price of a Starbucks coffee, which I think I'd be prepared to pay for a depression-free day. The study which Brickman mentioned earlier in Chile, the stepped care for low-income women, found that the intervention was effective but cost more money, but the additional cost was less than the one-way bus ticket price in Santiago. So yes, it costs more money, but it looks like it probably is worth spending that extra money. Or it could be cost per individual returning to work. A second way of doing it is saying, well, let's hypothesize a range of values that decision makers are willing to pay and see under what circumstances the intervention looks cost effective. And increasingly now you'll see studies, pretty much every economic study around will use this acceptability curve, which is trying to show that trade-off that individuals make, decision makers make, when thinking about whether it's worth spending a bit more money to achieve better outcomes. And the third approach is to use a generic outcome measure and perhaps compare with an externally generated benchmark. Two good examples of that. One would be the WHO's Choice Programme, which is particularly emphasising the cost per DALI averted. And you can begin to compare between different interventions, different therapeutic areas. In England and Wales, we have a body called NICE, National Institute for Clinical Excellence, which, if you go onto the, when you've got a spare moment, go onto the NICE website. It is a fantastically helpful website for reviews and source of information. But they have a criterion called cost per QALY gained, quality adjusted life year, which is not dissimilar from a DALI, but is not driven quite so much by clinical, not dominated by clinical concerns quite so much, I would say. But it's the same sort of thing. It's setting a benchmark for comparison. Okay, I'll skip the value judgment. I'm just going to go to this and I'll finish on this slide. High-income countries then, there is a rapidly growing evidence base on cost effectiveness. Some countries have mature processes. By that I mean transparent, participative processes for discussing is it worth it questions. And governments and funders have been willing, not always, to spend more to achieve better outcomes. This might change with the recession, but it's generally been okay, and cost effectiveness is gradually being properly understood. In a low-income country, the evidence base is tiny and growing only slowly. The WHO's Choice Programme is a very good example of how you can get some evidence together, but that suffers, shall we say, from being based partly on simulation. That's not, I think it's a very good thing actually, not a bad thing, but sometimes it makes it hard to make the case. And even when evidence exists, will it be used or will it be influential? So cost-effectiveness arguments can be made, but often it's an uphill struggle. So I'm going to stop there. I've got 847 slides still to go, but I'm sure you don't want to spend all night listening to them, looking at them. I'll come back to questions and points I want to make in the discussion. So thank you very much.
Well, first a word of thank you for inviting me here. It's fascinating to come back again and address people interested in global mental health. But having said that, I suffer from the dual disadvantage of whatever is worth saying already having been said by the earlier three speakers and a tired audience. But fortunately, the case that was proposed to be made or denied has already been done. So I think I'll move on, assuming that developing economies can no longer afford to ignore mental health, to say what should be done about it actually. And being in WHO, I'm being very practical. We can do a few things and let's go ahead and get them done. I see in the last 10 years a very clear difference in the attitude of policymakers and other people when we travel to countries. When I go to the Ministry of Health in Uganda, but that's very, very unusual circumstances, but even in Mozambique or in Sri Lanka. When I went 10 years back, the ministry people were asking me, what is mental health? Is it really health? You know, do you mean people who are crazy? Do you mean people who are in mental hospitals? And why is WHO spending time on this? But now that's no more the case. I think people are understanding now that mental health is clearly a part of health. It's worth spending time on that. There are needs in the countries. Nobody is saying there are no mental illnesses in developing countries. So we have reached really a stage where that argumentation is much more sophisticated and hence the action. So that's where we come in and say, okay, what can we do now and hopefully what can we do in future? In short, advancing the cause for global mental health all over, but especially in low and middle income countries. We do a lot of things, many of them quite useless, but we take pride in doing at least some things which we believe are useful, and hopefully other people also believe they're useful. I would focus my attention on 4 things that we do in the area of global mental health: generating and disseminating information, generating and disseminating knowledge and evidence, knowledge word being, I'm a little bit uncomfortable with that, but that's what WHO asks us to do. Technical assistance to countries and global consensus building. Let me go through each one of them one by one and give you some examples of the kind of things that we have done in the last 10 years. Much more for making aware. Of course, all of that and more is there on our website, so you could perhaps get much more information on that. So, Atlas has been referred to by earlier speakers. That's one of the projects that we are really proud of. We collect information from all countries, low, middle, and high-income countries. Pallab Malik, who's sitting here in the audience, was the one who started this project in 2001 and was working in WHO. We have done another exercise in 2005, and we are now doing it in 2010. We collect basic data on mental health resources, not on epidemiology, but on resources. And we make it in a comparable way, using some standard definitions, and make it available to people who want to use it. This is all available online. The database is there. There is no point noting down this URL. The best way is to just say Mental Health Atlas in any search engine that you use, and that will be the first website that comes in. What does it do? It provides you with information which you might need for a particular country, or you might want to compare information between different countries, the kind of charts that Vikram Patel showed, and all that is helpful in getting the information to be used. This is the homepage for the website. This is the kind of chart that you can make actually online. You can select countries and make these kind of charts. And as Vikram pointed out, it shows the tremendous discrepancy, tremendous disparities between what some countries have and what some other countries have for the same thing. And that is something that we are very keen on disseminating information on, that countries are at various points of what their resources are. And this is perhaps unacceptable anymore. So we need to do something about that. This is the kind of map that you can make from the data online. And just to highlight that there is, again, so much of wrong. Okay, I'm looking for the pointer. Oh, it's here. So you can see that in Europe there are so many psychiatrists, and in Africa there are so few, and so on. And that really gives us the kind of going to psychiatric nurses, again, the similar kind of figures, that there is so much discrepancy between what Africa has and what Europe has and for what America has. So these are just examples of information being there on WHO website. We have done some other atlases, Atlas for neurology, Atlas for epilepsy, for child and adolescent mental health disorders, for psychiatric training, for nurses in mental health, which we think is a very ignored area. So we came out with the special nurses for that, and global resources for persons with intellectual disabilities. But we were not happy with Atlas. It did provide a global resource for people to use, but it didn't provide really information that policymakers can actually use to plan what they would like to do. And we started a new project then, which we called the Assessment of Mental Health Systems, and we constructed an instrument for that, which has very clear definitions of what we're talking about, the kind of indicators that we would like to have from various countries. And we've done it now in about 80 countries. And this actually map is an old one. There are many more countries which have joined in. And this is the kind of information that we can derive, which is at a much higher level than Atlas could ever give you. What is the treated prevalence of users in mental health facilities based on 42 countries' data? And you can see that the treated prevalence in low-income countries is much less, a small fraction of what the upper middle countries have. And remember that this does not include the higher income countries, because we never worked on that. This could be, if you drew a bar of that, this will go from above the roof. So really that's what we're kind of talking about. And again, if you see for the regions, there is a clear disparity between many regions as to how much the treated prevalence is. So we have kind of moved from basic data to something much more that can be actually used in policy planning. We also produce country reports, and now there are about 55 country reports on our website. So again, if you search for who aims Uganda, you will reach that country report, which is in about 20-30 pages, describes all the information that we have on that, which people find quite useful. We also maintain a suicide database, the prevalence of suicide all around the world. And this is a chart just showing the world regions which have a much higher suicide rate in red compared to others which have much less. And obviously you can see a big gap here. Our statistics from Africa are very poor. So these white areas are where there is no data available, because there is no reliable data from these countries. We also have an alcohol database which gives you a lot of information on what is the alcohol consumption as well as problems associated with alcohol use in countries all around the world. This is by far the largest and most accurate database in the world for alcohol problems. Of course, we do the global burden of disease. I should say we are proud of having done that along, of course, with other partners, but we also very clearly recognize the limitations of this approach. And a lot of assumptions are made, a lot of simulations are made using Martin's terminology. But still, it does provide a kind of rough basis for comparing the burden across the health conditions. And as you can see, the neuropsychiatric disorders burden is very high and continues to be so. We have the last figures from 2004, but now currently we are working on the 2005 and subsequent figures along with the institute in Seattle. And hopefully by the middle of next year we'll come out with the fresh estimates, which again hopefully will not see too much change. One of the interesting facts on global burden of disease study is that actually prevalence doesn't seem to change the burden very much. It's the disability weight which is critical. And that's where the methodologies are being developed now, so that we have a much better handle on how much the disability weight should be. And that seems to make much more difference than the prevalence, which doesn't change actually very much. So this is the kind of charts that we could make from the global burden of disease. Leading cause for disease burden for women aged 15 to 44 years in high-income countries and low and middle-income countries for 2004, unipolar depressive disorders comes out at the top. We also have estimations for future, 2030 rankings for leading causes of dialysis lost. All over the world, HIV will be the top, depression will be second. But what is quite interesting is to see that even in low-income countries, depression will be the third leading cause, and in middle-income countries, second leading cause. In fact, Alzheimer's is going to come up in high-income countries as a third leading cause. So neuropsychiatric disorders seem to be not only very burdensome now, but in future, their rankings are going to go up. Again, let me remind you, not perhaps because the prevalence is going to be much higher, but because other conditions are going to be less burdensome in a way. We are going to get much more kind of handle on that compared to this, which is actually sad commentary. We should be doing much more. So I don't feel very proud about presenting this slide, just because we are saying that this is going to be not only burdensome now, but will continue to have a higher burden compared to other diseases. That means we're failing, actually. But still, these slides are useful, these figures are useful for highlighting some of the needs in this area. This is a kind of slide which WHO again makes, burden versus budget. A lot of assumptions there, and I'm sure a lot of you will jump over and say, no, this doesn't make sense. But it does make sense when we go to policymakers to say, here is the burden, very high, and here is the budget that we're assigning to this condition, which is a fraction, even in high-income countries, leave aside the lower ones. And again, gap in treatment. The World Mental Health Survey has very clearly shown. I don't have much confidence in comparing the prevalences across the world. There are many problems there. Whether the instruments are equally useful, they are feasible, how reliable are they, and so on. Even the definition of mental disorders, whether it applies the same way in high-income countries versus the low-income countries, is very much doubtful. But I have much more confidence in looking at the gap in treatment from the same surveys, and it clearly shows that even in developed countries, almost 50% people are not receiving any treatment at all. And we're not talking about adequate treatment or satisfactory treatment. We're talking about any treatment. And in developing countries, a vast majority of people are not receiving anything. That is the message to policymakers, that you are, in this year, not looking after the majority of people who are suffering from mental disorders. That is the argument that we do want to use. Leave aside the cost effectiveness of that. Are you doing a good job by not providing any care to majority of people that are suffering from these disorders? We also make instruments for use like ICD, International Classification of Diseases. These were published almost 20 years back. The 3 versions of ICD, and currently we are revising ICD-10 into ICD-11. And we'll be grappling with some of these issues. Does culture have an influence on the definition of mental disorders? Do we need different criteria for the same mental disorders across different cultures and countries, or not? And these are the kind of things that we're doing for the last 2 years. We'll continue to do this for the next 3 years, and we expect ICD-11 to be available in 2013. Let me shift over to evidence from information. We don't collect evidence, but we do analyze, evaluate, and make evidence available for use in countries. And this is an example of evidence for promoting mental health as opposed to treating mental disorders, which we published a few years back, which is being very widely used in many countries, and a similar report on prevention of mental disorders, what exists right now, what public health measures can exist for prevention of mental disorders. We also have very lately, last year, published a report on integrating mental health into primary care, where we present evidence that can be understood by policymakers into why mental health should be included and integrated in primary care, and how to do that. There are many examples in this report which tell us how that can be done, really. We also have a number of modules, basically resource material, for policy and service guidance for countries, and there is a whole list of them again on our website, which help people, especially in the policy area, to understand what can be done right now with the existing evidence that is available. This is the kind of chart that we produce, not for policymakers, but for policy advisors. And these kind of figures come from the WHO Choice project that Martin has already referred to, but also taking it forward to say what kind of resources will be needed in many countries, especially from developing world, if they want to deliver standard basic package of care for selected mental disorders. And here are 12 countries for which data was analyzed based on where they are right now and what kind of resources are there and what they need to spend in the coming 10 years for delivering the kind of basic package that we think is very much necessary for that. And all of the contents of these packages are of effective interventions. I would not say cost effective because that's relative, but at least they are effective. So we are certain to demonstrate to countries and advocate for these packages, these interventions to be delivered. And this is what the kind of monies that will be needed on a per capita basis for doing that. We, at this point of time, are engaged in making a standard evidence-based intervention package for 8 conditions. And we have done a very thorough systematic review of all evidence for interventions that are feasible and effective in non-specialized healthcare setting. We are not talking about interventions to be delivered by psychiatrists and clinical psychologists, but by primary care people. And when I say primary care, I include physicians, but also nurses. And in many countries, healthcare providers who are don't have a degree. And what interventions can be effective in their hands. And we have done a systematic review, and we have now come out with 90 interventions for 8 conditions, which are being packaged at this point of time into a model intervention guide, which will be for use in low and middle income countries. I have a feeling that this guide will actually be useful even in high income countries, because there are many low resource settings in high income countries where even this basic package is not being delivered. And that perhaps be an experience to go through, but at least we are targeting it for low income countries and middle income countries where the needs are the maximum. And we are going to put all this information on the website so that anybody could go ahead and use it. However, providing information and evidence is actually a task that we do in the service of providing technical assistance to countries, which is an active process rather than a passive process of delivering information to them. How do we do that? We have tried several methods, but currently we are focusing on all of our energies into running one single program, which we are calling Mental Health Gap Action Program, which has the blessings of the highest quarters within WHO as well as within the UN system. And a number of countries have expressed a lot of interest in this. This is the basic document available in many languages, which illustrates some of the basic principles of this program. Essentially, it's about scaling up care for mental, neurological, and substance use disorders. We think it's logical to think of these disorders together rather than to think of them separately, because the service systems in low and middle income countries cater to all of them by the same healthcare providers. We have identified 8 priority conditions based on high burden, including mortality, morbidity, and disability, large economic cost of these diseases with all the limitations pointed out by Martin earlier, and effective interventions being available. And the list now is of 8 conditions, 4 from mental health area: depression, psychosis including schizophrenia, suicide for prevention, and child mental disorders, 2 from neurology, epilepsy and dementia, and 2 from substance use, alcohol and drug use disorders. So these are the 8 conditions that we are going to countries with and saying, if you can do something about these 8 conditions, you're doing well. Leave aside the other 200. It's okay, because these produce the largest amount of public health burden, and something can be done about these disorders. Our MH gap strategy is about scaling up, because we believe that the amount of information that is available, which can be used for delivering care, only a very small fraction of that is being used. So we are all for generating new knowledge. We would love to have the causal factors for schizophrenia found out and the latest interventions, drug or psychosocial, being discovered. But are we using what we know? The answer is no. We are not using even a small fraction of the knowledge that we already have. So our program is about scaling up the existing knowledge. It's used for delivering care within the countries and delivering care for prevention as well as treatment. Much of the need in low and middle income countries being for providing treatment, although prevention is following and many evidence-based interventions are coming on that. So we do assess the needs and resources in these countries. We try to create a political commitment. In many cases, having a family member of the Minister of Health suffering from one of these conditions is a bonanza for us. It's very sad to say that, but that is the entry point, where we can actually get our entry to the minister's office directly before being stopped by the whole army of personal assistants whose job is to, as a gatekeeper. And that is the reality. When we go to countries, we have to find all methods to get into a high level of policy making. And in some cases it works, in many other cases it doesn't work. We also then create a supportive policy environment, in many cases changing the policy, as has been explained earlier for Uganda. Changing the policy is a very serious decision, and it takes sometimes years to do that, but we try to do that. We develop a scaling up strategy for the country specifically. We then try to deliver the intervention package, having developed the intervention package ourselves, strengthening human resources, which essentially is a very serious task. In fact, if you ask me, is there a problem with money? I think no, that the primary problem is with human resources. It's not about money, it's about people, and that is our basic constraint. So this is extremely important. But of course, to get people, you do need money. So again, there is the issue about financial resources and also establishing a plan for monitoring and evaluation so that we can actually demonstrate what the impact of all this has been. Final goal being a reduction in treatment gap and then a reduction in disability, of course. Our last activity that we think is a useful activity for WHO is consensus building, and I'll give you just a couple of examples on that. The World Health Report 2001 has been referred to earlier by speakers, and that's something that we spent a lot of time doing, and I think it had a very good impact. It is, again, very sad to say that the 10 recommendations that we made in 2001 are exactly the same recommendation that we are making now, because the world hasn't really moved much forward in the last 10 years. So we are again talking about same recommendation, providing treatment within primary care, simply because specialist care is not available and will not be available in the near future in many of these countries. Of course, supported and supervised by any specialists who are available, making psychotropic drugs and psychosocial interventions available in the countries, giving care in the community and not in mental hospitals, educating the public, involving communities, families, and consumers in the healthcare, establishing national policies, programs, and legislation, develop human resources, linking mental health with other sectors within health and outside health, monitoring community mental health, and of course supporting more research. And when I say supporting more research, our focus is on supporting research which leads to better implementation. That we think is the paramount importance right now, rather than to find other things which of course are needed. But from WHO's perspective, we are more interested in that kind of implementation and programmatic research. We also have built up a consensus around what should happen in low and middle income countries as far as services are concerned. And this is a pyramid which has been very often quoted and used. And of course, we are very happy about that. Basically saying that mental hospital and specialist services are needed in all countries, but they are very high cost and they should be used less often, as opposed to psychiatric services in general hospitals and community mental health services, which are somewhat less expensive but are more often used. Mental health services as a part of primary care, then informal community care, and self-care. Unfortunately, the reality is that this pyramid is lying on its top. So basically, we have a large amount of mental hospital care and very little amount of PHC or other care. We want to really reverse this triangle in many of these countries. That is the task. How to scale down mental hospital care. These are terrible asylums where human rights are violated every day, and how to incorporate mental health within the existing healthcare system in primary care. That is the need right now. Of course, a much larger need is also how to involve communities in care, how to prepare the communities in providing informal care through any means available. It may be religious, it may be spiritual, it may be other things. Informal social systems, those are really the protectors of mental health, and we need to spend really more time about how to strengthen them so that mental illnesses can be prevented and looked after in a way that is less stigmatizing, and less burdensome. The Lancet series has been referred to. In fact, this slide has been shown, so I'll move on. But we, again, are happy that we were part of the Lancet series to come out with a very clear action program to scale up services, which we are actually acting upon now. So we were advising ourselves, and now we're acting upon that, which actually shows the consistency of our approach. I talked about human rights abuses, and many other speakers talked about it. This is a real shame. I think there is one side, which is the science and the effectiveness and the cost effectiveness of it, but the other side is really the moral case. Can we really afford to ignore the people who are living under terrible conditions all over the world? And this is not the condition only for low and middle income countries. This exists actually in very high income countries also. Some of these examples are taken from Africa and Asia, but also from Eastern Europe. I'm sure there is perhaps no country where the human rights abuses are not there against people with mental disorders. In many cases, they can't vote, they can't drive, they can't come out of a mental hospital where they were admitted many years back, and this is something which troubles us a lot. And we do want to combine the human rights argument with the science argument to make a case for the economies of the developing world. I did talk about alcohol a little bit, just to inform you that WHO for the first time is going for a strategy on reducing harms associated with alcohol. We know that it's a very politically sensitive area, and in WHO we need the consensus of all countries to be able to make a policy, and this was not possible for the last 20 years, but now in 2010 it is becoming possible. We have the last hurdle. In May 2010, in 2 months from now, all the ministers of health will meet in Geneva and will vote on the global strategy for alcohol. And if there is one country which says, no, we can't have it. So it's still not too certain, but we're hopeful that the countries will actually pass this strategy, which is not binding. WHO will not say that you must do it and you sign there, but it's the recommendation that from public health viewpoint, some of these actions are necessary, and alcohol should be treated not as an ordinary commodity, but as a serious threat to public health. That's what we're trying to say. And hopefully, I can come back sometime and say, yes, we did it. A word about MDGs, which has also been referred to earlier, MDGs being essentially a UN initiative we feel very much responsible for, and also somewhat part of MDGs. And we are, of course, very unhappy that mental disorders or even chronic disorders, chronic conditions, are not part of MDGs, are not part of the indicators which have been selected for that. We are trying to prepare a case for linking mental health and substance abuse with existing MDGs, and there are many links. Vikram has actually written an article on that. We have many summaries to say how mental disorders and mental health in general and substance abuse can actually be a threat to achieving other MDGs. And there is a strong case for that. But we're also trying to make a case for a new MDG on chronic diseases, including depression, because we believe that these are serious public health issues which need to be taken up at a global level based on a consensus. In September, there is a meeting in New York to look at the MDGs, and we are preparing a case for that. To be honest, we don't feel that there will be a new MDG, because the progress on achieving the MDGs all over the world has been not so satisfactory. So I don't think countries will be very keen to have another new MDG. But I think there is a big advantage in at least preparing a case for that, because even if we don't succeed to have a new MDG, there will be clear links with the existing MDGs, and perhaps countries will get a message that this area, although not a part of formal MDGs, is an important part. So we are working very hard to produce that kind of case. So coming back, I know that I have only 4 minutes left, but I need only about 2 minutes out of that. These are the 4 things that I'm highlighting today, the so-called useful things that we think we do. How do we do it? We do it in partnerships. We are a bunch of 20 people sitting in Geneva who are trying to do all of these things, which is a small fraction of prestigious academic department like this. We believe that we managed to do some of these things by partnerships. And fortunately, we have a number of partners who are very happy to work with us for money, without money, just for praise, just for a pat on the back, and we are very happy to have partners like that. Our main partner is governments. We are an intergovernmental agency, so our main partner is the governments in the countries, 193 at this point of time, ministries of health, and we are fortunate to have a direct access to these ministries, and we really have these as the basic partner. But we have other UN agencies who are partnering with us, and they help us a lot. We pride ourselves in having good partners in academic institutions, like where we are, with NGOs, which we again feel is very important. I know that the number of you here are from NGOs, and that is a very strong and a growing force for providing evidence as well as action on global mental health. But lastly, and not unimportantly, we have good partners in consumer and family groups, and we think that is something that we should grow, because I don't think we can move forward without really having consumers and family groups with us. As they say, nothing about us without us. And I think we think that's a very important message to be given. Thank you very much.
So with that, I would like to invite the four speakers to come up so that we can begin to have a panel question and answer, but more importantly, I hope, a discussion and conversation where you as the participants also come and add in thoughts, questions, and ideas. So I'd like to invite our panelists to come up.
You want the end, okay.
So I would ask, are these on? I would ask that when you do come up to ask a question to one of the speakers that you introduce your name and say where you're from. I'm going to take the prerogative of being able to ask the first question, since I was the organizer of the event. And I'd like to start off with something that I think is relevant for many of the people in this audience, which is that we're at a research institution. We're training students to be practitioners, but also public health researchers. And so I would ask each one of you, given the sort of hopeful as well as challenging issues that you raised, where the knowledge is and where it isn't, where you think the next steps in terms of a research agenda, and where our students and where the faculty can go in terms of thinking, what can a research institution do to move the field forward into getting mental health on the agenda in a positive way with services that actually help the populations? Who wants to go first? Just take it on.
I think I touched on this in my talk, so I'll just repeat that. The most immediate research agenda really is the implementation research agenda. Fancifully, I think we've started calling it implementation science. I think partly because the dollars weren't coming to just what we used to call it before, health services research. But I think it is a science, because if science is the way we discover ways of doing things, as much as what is new in the natural world, I think it is science. So questions like how do you actually deliver the things that we know work in the real world, and how we can scale them up so that they can increase the coverage of those services are very important questions. But I also think beyond that are research questions that have long been the heart of psychiatric epidemiology, I think remain extremely vital and important. And here I also include medical anthropology and disciplines that contribute to our understanding of mental disorders in different groups.
I completely agree with what Vikram was saying. but add two things. One, that my first advice is become real. I think the distance between what you research upon and what is actually feasible in the real life situation is still too big. And I think we need to focus our research on things that are being done and can be done better, rather than things which should be done and we know will never be done. So become real. The second point I want to make is that doing research on health service delivery in low and middle income countries is going to be, of course, useful for those countries, but I believe it will be very useful for the countries which are in a very different environment. Because I think there are common messages that we will get, and that information will be useful globally rather than only for those countries where we are going. Thank you.
Strictly in order. Okay. I mean, I would just offer two suggestions about the process by which research gets undertaken, I think. And one would be, I mean, these are both lessons that we're learning in our research in many contexts, would be to take the advantage to weave in two things which have been neglected a lot, I think, in research so far. One is the user and carer family involvement or perspective, not just, asking them questions, but actually involving them in the design of the study and the implementation of the study, because that will improve hugely, I think, the quality, but also improve the implementation of the findings. And then secondly, if I just play the role of narrow economist for the moment, I would say, again, I mean, a lot of research goes on, and I often come across some fantastic studies in the journals, and I think, why wasn't there economics element? Because it would be such a small additional cost to add that in, and yet the payoff could have been quite, I mean, the payoff has been great anyway, but the additional payoff could often be quite substantial in persuading decision makers. So, I mean, I would just plea add economics in.
And mine will go back to the policy, doing research on the policy process, because however much of the evidence we have, until we have a better understanding of how to actually translate evidence into policies, I think that is important. I also think we also need to move out of the very narrow medical model approach and move more into the social determinants and then the social outcomes of mental disorders. Because if we remain very narrow in mental health, I think somehow that's why we keep talking to ourselves, and yet that is not really getting us anywhere. The other one is others outside of them, like, for instance, traditional healers. 80% of our patients in the developing world go to traditional healers. Why do they go there? And is it cheaper for them there? Is it more effective for them there? So there's so many things we don't understand about that. So I think we need to do the lay providers. There's this whole thing about moving into community care. And moving into community care actually moves the care burden to the lay providers, the families, and nothing is provided for them in that process, especially for us in the developing world. It's not like you get community programs and then you get money in those programs. They say we are moving into community care. It essentially means families are going to look after their patients, and that's about that. And what is the family burden?
Thank you. And I would just add that one of the things that we've been talking about within our research group and more widely with many of you before is also coming up with some common metrics, some common outcomes that we can use across different disorders and across different types of programs, and starting to look at being able to compare like with like, so that we can start thinking about different types of interventions for different types of contexts, for different types of populations, economically and mental health. So I'd add that as an additional area.
Hello, I wanted to say I enjoyed each one of your presentations. Thank you very much for taking the time, the great time that's involved in coming here.
Can you introduce yourself?
I'm Anita Everett, Dr. Anita Everett. I'm a community psychiatrist from the Johns Hopkins Department of Psychiatry, but I've done some work internationally. As you are probably aware, we are in our own country right now are having, even this week, quite a debate on healthcare and how healthcare is going to be delivered and financed, or may not be changed in our system. One of the things that's at the core of that for us is central government versus state level or government or provincial regulation and financing of healthcare. And there are a group of us nationally who are very invested in the idea that mental health would actually do better if it were a central government sort of thing, or a federal government in our case, if it were more pooled and worked together that way. So I'm just wondering from our panel today if you have any opinions on whether mental health itself in the context of government services does better in a central government versus dispersed provincial control or even local government control.
I could have a go. I'll go first. I'm not sure I understand the US system very well, but taking the example of Uganda and when we had user charges, for instance, I think for me the challenge is, should we treat mental disorders different from other disorders, and why should we do that? And I think it goes back, for me, it goes back to the issue of stigma and saying mental disorders are different from other disorders. And every time something is being done and we carve out mental and put it aside, then we end up getting differential treatment for mental disorders that may not necessarily be better. It may be that you end up getting, like for instance with user charges in Uganda, what happened was people coming to the mental health clinic did not have to pay a fee, but then the user fees were being used to improve quality and to improve the motivation of the health workers. So as a result, the health workers working in the mental health units were not getting that motivational allowance, and their services were not being improved because they were not contributing to that budget. And in that way, it acted against them. So if we believe that mental disorders are like any other disorder, then my impression is they should then be like any other disorder in all ways. I don't know what others think.
Well, okay, I'm not going to answer your question, but I'll ask you. I mean, I can think three reasons why you might want to go for a more centrally organised, centrally regulated, monitored system. One would be that I think there are certain mental health problems that are relatively rare but often very severe, and local agencies are not going to build up critical mass of experience with those. So, you know, the psychosis is a good example. I think sometimes you need to just step back a little bit to get that critical mass of expertise and provision and so on. So that's one. Secondly, something that Florence said, I think stigma is a good example of a big issue in mental health, which is really a national issue. I mean, there may be regional and other variations, but this is something that needs to be tackled through national policy and maybe monitored in some way nationally. And then, of course, the third thing is there are huge variations in every country I know in the level of provision, in the quality of provision, in the outcomes that are achieved, and so on. And you need to make sure you keep an eye on those variations, and that needs some sort of national oversight. It may be a lack of national influence, I don't know, but I think those are three reasons for me that would push towards a more national process.
I think it depends on the country, but for the country that I know well, it's both. There are some functions which have to be at the central level. This includes the basic policy framework, the legislation, and the overall program, the directions, which need to be central. Otherwise, there will be too much variation from state to state or province to province. However, the actual provision of care has to be so well integrated into the healthcare system, which in most countries is decentralized, that you really have to see how it can be integrated within the local system. So I think it's a combination of that, and we have very good examples of that. Federal government can have certain not only directions but also certain special initiatives to actually push provinces into providing the kind of quality care that it thinks needed. The director of mental health in Tanzania, I was speaking to him a couple of weeks back. He spends now 50% of his time just traveling to provinces and convincing the provinces that it makes sense to provide this kind of service, because he, being the director of the federal government, cannot have any power on the provinces. The money is allocated by the provinces. So one of his jobs is actually convince the provincial authorities. And I think he's doing a good job. So it's a combination.
We'll alternate between sides.
Hello, I'm Jennifer Weiss. I'm from an NGO called Project Concern International. And thank you all very much for your presentations. I thought they were really, really fascinating. My organization's involved in, not explicitly involved in mental health. We do international development. Specifically, I'm involved in our HIV programming. And through that programming have obviously started working with mental health a lot, you know, sort of by accident, by beginning with the provision of psychosocial support, what we refer to in the HIV world, to children and adults who have been affected by HIV, and then gradually just seeing the need, doing more and more, and being able to be involved more and more in formalized trainings. And I believe a lot of your presentations touched on the opportunities that are involved with moving mental health screening and treatment to primary care and training lay health workers, which we've certainly seen a lot of opportunities as well. And I would just be interested in hearing some additional comments from you all on that. How has that worked so well? What does the evidence say about lessons that will help to scale that up, and what have been the challenges in that model as well? Is there a risk of relying too much on that model as opposed to strengthening sort of a broader, more systemic level? Thanks.
I have to admit, I'm not quite familiar with an evaluated model of integrating mental health care in a routine HIV/AIDS care program, but I know there are many attempts to do that that are in progress, including the one that you've just described. I met someone at the tea break who said that in one of the PEPFAR programs, if she's in the audience, she might actually have a more substantive answer than I do. But what tools I can direct you to are the integrated management of adult illness for people living with HIV for district-level healthcare providers, produced by WHO, which integrates within the entire package of disorders for people living with HIV, depression, psychosis, and so on, and dementia as well. So there's a very nice tool that's available, and that's integrated, not a separate from TB and so on, but actually it's a single unified tool. And there's also a set of tools for psychosocial work with people living with HIV, also in fact sponsored by the WHO. So I'd recommend that, you know, there are resources out there which have been developed quite systematically, and I think that'll be quite useful for you to use. And finally, please describe what you've done, because I think there is a huge evidence gap, and even narrative evidence of describing your program and, you know, what outcomes you've achieved, what interventions you put in, etc., is extremely valuable.
I'll add a little bit to it, because we have done a lot of work working with community health workers or community workers who we've now trained in health and mental health. And you know, it sounds like in part you were asking about the integration with HIV, but also a little bit about, you know, how does one actually do that when you don't have a health professional, or when you're trying to work with the lady health workers or the lay population. And I would say one of the biggest, I wouldn't call it a barrier, but one of the biggest concerns or things to keep in mind in terms of what we've seen in terms of successful programs is a real recognition of the importance of supervision. So that it's not just about training your lay health workers and letting them go implement a program, but it's training lay health workers with supervisors who have more mental health. And I think this is moving towards what Vikram was talking about earlier, this role of task shifting, but not with task shifting, it's a shift. It's not moving. And so where there has always been systems of supervision, even at the highest levels and the most clinical levels, it's making sure those systems are still in place as you move down the line in shifting it towards people with fewer skills. And so I think thinking through what are the systems in place for the high resource areas or the high context skills, and making sure those are in place as it's moved down the line.
Hello, I'm Kiana Brown, a first-year PhD student here at the School of Public Health. And my question is about training mental health workers, and Dr. Bass has begun to answer it. Are there any recommendations on how practitioners can go about training lay health workers or community health advisors, specific areas to train them in, and how to sustain a network of community health advisors in mental health?
Well, yes, I think right now I think WHO is producing something on training community health workers. That is one, but training. There's nurses, and nurses all have a curriculum. In Uganda, at least they do have a curriculum, and nurses are not, well, we do have some degree nurses, but the majority are non-degree, they're diploma level nurses. And every single nurse has to get training in mental health in Uganda right now. So I think the basic training is not more the issue, is not so much the big issue. The problem is when they do go out, they're not very confident in providing the mental health care. So when they're in the clinics, they're not seeing the people with mental disorders. So what Judy was just saying right now, the follow-on support and the support supervision, so somebody comes in every month or every quarter, like the lady health worker that Vikram showed, that seems to be much more important in getting the health workers more confident in providing the service rather than the basic training that they get. It's more the supervision that they get and the support supervision and the follow-up. Yeah.
Can I just add one thing? So as a practitioner, it's ethical and acceptable to train your community health worker based on the skills that you have, be it nursing or social work or et cetera? Is that how it works?
It's in Uganda at least. In Uganda, what happens is the curriculum is developed by the Ministry of Health for the community health workers. So then the Ministry of Health trains the first initial training is done by the Ministry of Health. But the follow-on support is provided by the next level of health worker. And that's more like Vikram showed, if you remember that picture, somebody sitting with the community health worker and watching them see some of their patients. And then after they finish at the end of the day or the next day or something, they sit down and discuss the difficult cases. Where are they having problems, whether they need help. So that is outside of the basic training. The basic training has to be a standardized manual.
Yeah, just to add to what Florence has just said, these are the sorts of questions that form part of implementation science, actually. These are exactly the questions. We don't actually have very good answers. For example, should the training be 3 months, 6 months, 12 months? Should it be something that covers the basic principles of mental illness, skills? Should it include medication initiation? We actually have manuals for different trials. So each of these different programs that I showed you will have a manual. Paul's trial will have a manual for the delivery of interpersonal therapy. Rahman's trial will have a manual for cognitive behavior therapy, and so on and so forth. But there isn't a manual built around stitching these together, which is then tested in the field to see in the real world, can you provide generic skills for community health workers to deliver a range of mental health care interventions for a range of mental disorders. There are manuals like Florence describes that are developed by policymakers, but they haven't either been evaluated either. So I think that is implementation science. Those are the exciting research questions that perhaps you might do in your PhD.
Hi, I'm Beju Gandhi. I'm a psychiatry resident at University of Maryland, and I have a question. What suggestions might the panel have for residents to get involved with global mental health? I have some experience with internal medicine-related trips, HIV, tuberculosis, so on. And I'm interested in getting more experience abroad in terms of mental health and specifically integration of mental and physical health. And I realize it's an easier question to answer when you have more focus. And some residency programs have certain opportunities available, but my question is, has the panel been exposed to residents coming abroad or other opportunities, either clinical or policy-wise?
Quick answer to that. Well, one quick answer which I just found out, if you're a US citizen, you should go to the Fogarty International Center website right away because they've just launched an international psychiatry residency program. where you can get fully funded 12 months for your residency in a selection of NIH-funded sites abroad. So that's one answer. And the other answer is that I think one of the skills that I don't know about your training, but I didn't get in my training in psychiatry, was the public health skills that I so urgently need to work in a low-resource setting. So if that's already part of your training, that's great. But if it isn't, then I would strongly recommend some form of public health training. Not necessarily before you go, but at some point of your career, if that's what you want to do. I think public health is a very important skill.
Maybe just to add to that, at George Washington University, they also have a global health program, and they also have to go out and do a residency of, I think, 3 months in the summer. And every year we've been getting a number in Uganda. I started the mental health program at George Washington University, but it's still going on there. But they don't have to focus on mental health. Many have come and worked in HIV/AIDS, for instance, but some do come and work on mental health. And it's like, if you think of coming and then you make contact with somebody in the country you're coming to, and then you discuss a project you can work on, and that's how it goes. It's the interest of the student, I think.
I'm Lawrence Goldberg. I'm a psychiatrist working for an insurance company in Philadelphia. I have sort of a two-part question about funding streams. Dr. Patel made the analogy to the success of the HIV movement globally to increase awareness and to raise dramatic amounts of money and to increase access to formerly expensive medications. The first part of my question is, given the current rather straitened global financial circumstances, is there a danger as we advocate for more funds for global mental health that will descend into a kind of an unseemly and mutually destructive competition for scarce resources with all the other worthy global health causes such as AIDS, malaria, tuberculosis, and how can we go about ensuring that the funds for mental health are new funds rather than sort of pirated funds from other worthy causes? And the second part of my question relates to pharmaceutical companies. Is there any movement toward approaching pharmaceutical companies along the same lines as has been done for these other conditions, such as HIV, malaria, tuberculosis, to get reduced cost psychotropic drugs available in underserved and low and middle income countries?
I can start. I think the issue is the word worthy. Who determines what is worthy? I think it's something that has to be, we have to agree that what has been decided as worthy today is what we're going to stick with forever. But I may not agree with what you believe is worthy, and so we have to keep having this discussion and then reprioritizing also, as well as different issues change. Yeah? So I think it's not about competitive funding, it's about and us having to say we're not going to touch your money, HIV, AIDS, or malaria, but we're going to find our own money that won't impinge on yours at all. But that's not how it is right now, because even right now the funding sources are shrinking because of the whole global economic crisis. And therefore that means that the bucket of money we're all competing for is shrinking, but at the same time we feel we want a bigger share of this shrinking budget, and so definitely I think we will impinge on somebody's money. But as maybe Martin will say, it's always, that's how it is, isn't it? and on the issue of pharmaceuticals, it has been done. I know that in Botswana, for instance, they provided a lot of money for HIV/AIDS. Botswana bought a lot of HIV/AIDS drugs, but as part of that, a company, I just can't remember which one, decided to provide HIV/AIDS depression treatment free of charge. Yeah, so there are those kinds of partnerships going on.
Just a quick response. I think the answer, I think, to your first question is in the way you pose the question, which is I think we need to take the debate and the competition, if you like, out from the health domain to look at other domains. We were discussing this over lunch as well. That if you start to have mental health competing with HIV/AIDS or whatever it is, then there's a no-win game. You've got to find a way of making the case in this shrinking economic world for more resources going into mental health from outside the health budget area, outside the health sector. And that's pretty tough, but then mental health, compared to many other areas of health, does have these big spillover effects in other parts of society and the economy, and making that case or making that information more widely appreciated might help to make the case for more investment in mental health. And that's certainly one of the cases I was trying to make. I think that's been happening, and I can think of lots of examples, although they're all in high-income country contexts, where you can make that case for money to come in from outside the health budget to support health initiatives. So I think that's how I would see it. In relation to the pharmaceutical company question, if I knew the answer to that, I probably wouldn't be sitting here today. So I think that's a big challenge.
Well, similar to what Martin was saying, I think we believe that health and education should anyway be receiving a much larger share of public funds compared to other areas. So I think what we're talking about is increasing the whole pie rather than our sector of the pie. I think that's the first point. And of course, within that there is competition, and I believe there is no better time than now to make a case, otherwise we'll be waiting forever. On the pharmaceutical companies, most of the medicines that are useful for the priority mental, neurological and substance use disorders are really not under patent. There is a fair competition, and a lot of producers are there. So I don't think the similarity between HIV drugs and these drugs is quite so much. Of course, there are other mechanisms by which procurement for these drugs could be done at a much cheaper price with bulk purchasing and other kind of mechanisms, which we are certainly exploring. But the issues are not exactly the same.
I just have an observation, really. It's not a response. It's curious that this economic recession is being used to justify cuts in health and in education and international aid, but not quite to justify any cuts in the sector which actually was responsible for the economic recession. And I find it quite curious how we, mug in, sit back and just quietly accept that reality. That's all. It's just an observation.
The one thing I would also add is if there is a place for pharmaceutical industry, it may also be, rather than just looking to them to potentially fund or provide pharmaceuticals at a reduced rate, would they be interested? Is there an interest in funding in providing non-pharmaceutical services? Is there a way to get them to think about health on the larger scale, particularly connecting mental health with the physical disorders that are so biologically related to many of the pharmaceutical treatments? That might be another way to approach it. So rather than just focusing on psychopharmacology within the pharmaceutical programs. Paul?
Hello, my name is Paul Bolton. I'm from here at Johns Hopkins. I just wanted to make a comment that I hope we're not overstating how much evidence we actually have for effectiveness of interventions across cultures. Vikram, you said, we know quite a lot. And Shekhar, you said you had summarized what information was out there for many interventions. But you also acknowledged that what we really need is effectiveness research. And we understand that across cultures, the effectiveness of these interventions can really vary for mental health more than they can for some other kinds of intervention. And when I look across what we know, I don't see much evidence. I actually see more of a desert, where for most countries and most cultures, for most mental health interventions, we have no effectiveness data. I was just asking Laura, my colleague, can you think of any child intervention for any illness that's been demonstrated to be effective in any developing country? Anybody? And part of the problem too is that we need the really good evidence that we need is actually in controlled trials, when I present some of the results of our Uganda studies, one of the slides I love to present to the students is, I have the slide for IPT and I write, here, before the intervention we could diagnose 85% of the sample as depressed. And after the intervention it was 30%. So we had a 55% improvement. And we're all impressed because that's a big change. And they said, well, actually that's the control group. The control group had a 55% reduction. And this is part of the nature of mental health, that if you screen people in who are severe, over a period of time they're going to naturally appear to get better, right? The idea of regression to the mean. And this is just one of the risks with mental health research, which means that we really need more controlled studies in more cultures about what it is that works. And I know that you didn't mean to make that implication, but I just wanted to make sure that we were clear on that basis. Because sometimes I think we might shoot ourselves in the foot if we push too far forward, and then when we have to admit that this is actually what we know, we can look a bit, you know, like we're just another tendentious group with our pet topic, rather than really approaching things from the point of view of science.
Well, I completely agree with you, Paul. In fact, I think I'm, of course, as you know, a great believer in controlled clinical trials and spend most of my life actually running trials. So you're talking to the converted here. However, the question really is, what are we actually testing the effectiveness of? A specific treatment or a delivery mechanism? Now, it's worthwhile taking a step back and asking the question, before antiretrovirals were scaled up in Africa, was there ever a randomized controlled trial of antiretrovirals outside North America or Britain? The answer is no. It's worth asking the question, are there any randomized controlled trials of antihypertensive, anti-diabetic drugs in the developing world? The answer is no. Actually, there are more randomized controlled trials in mental health than there are in cardiovascular disease in developing countries. So the question really is, do you expect is there a reasonable ground that, for example, a biological treatment would function differently in different populations? The answer that people in the HIV or the cardiovascular field have assumed is no. The questions are delivery. In the case of mental health, we have two kinds of issues. Firstly, psychological treatments. Those, I think, there is much more ground to believe that there will be, in fact, quite a lot of variation potentially in treatment effectiveness, which is why trials like yours are so important. The second are the delivery questions. The delivery questions are extremely important, and we actually have very little evidence on that, and that is a research agenda that I suggested is a priority. There are also subgroups of mental disorders, like child mental disorders. I completely agree with you. We desperately need more evidence. In fact, in the priority setting exercise that I described, child mental illness interventions was the highest ranked intervention that was prioritized, and the second one was alcohol abuse. So we have evidence in depression, at least 4 trials, which I think is actually not bad, given the state of the field before 2003. We have some evidence for schizophrenia and some for epilepsy. I think we can start taking some actions in those areas. Where we don't have evidence, I would certainly agree, we need to build that evidence.
Just a quick response. I mean, we're just talking here about the difference between efficacy and effectiveness trials here.
Absolutely.
And I'm not talking about efficacy trials. I'm talking about effectiveness trials.
Well, that's the implementation agenda. Yes, we desperately need to do that. But I think we need to marry the implementation research agenda along with scaling up. I am very concerned if we say that we should not take any action on the evidence we have until we build that effectiveness agenda, because we are placing then certain hurdles in front of us which are unlikely to be overcome for the foreseeable future. But also, I think we need to ask ourselves, are these same questions being used as hurdles to scale up treatments for hypertension, diabetes, or HIV? I think they're done side by side. I think scaling up and implementation research on effectiveness could be done side by side. In fact, the scaling up opportunity is, in fact, an opportunity for doing implementation research. That's the way I would put it.
I agree, but my point is that I think if we give too much the impression we already know what to do, that second part of the agenda, where we do them side by side, gets lost.
Well, we say what treatments. We have some idea of what treatments we can use, but I don't think we can say we know exactly how's the best way to deliver them.
Well, let me give you just, and then Shekhar can answer. I mean, one of the issues we had, for example, recently was we went to an organization and we asked for funding. We had this conversation back and forth about, yes, we really need to assess these things across cultures. And then it came to the point where we said, well, we would like to do a trial of this particular intervention. And the answer was, well, you guys have already done a trial in Africa. Why do you need to do another trial of a mental health intervention in Africa? Point being, I think this gets lost. I think people do say, yes, we've done it once, and we're good to go. And yet the trials we've been subsequently doing, including trials now, I wouldn't do the interventions the way we did them before, based on what we're learning now. I just feel like this parallel process is getting lost, and I don't mean to take up lots of time.
Just a quick response to continue the dialogue. I think there is a danger in what you are saying, danger of overstating the case. Certainly it does exist, but there is the other danger of being paralyzed into inaction. And I see that danger in many countries to be much larger. So obviously we have to strike a balance. But I think what Vikram is saying is we could do it parallelly, and I think you're agreeing with that. So not to ignore effectiveness, but to integrate that within delivery mechanisms so that we can have answers which are already ongoing with the program implementation. That's what we think should be done.
Great, I agree. I'd just say I think that that's getting lost. But I'll leave.
Just one quick response as well. I think what the research community has not done very well at all, I absolutely agree we need more trial-based evidence, but what the research community has not done is actually to provide guidance about how you can generalize from, a trial in this context to a different context. I mean, it's a terribly haphazard process, and I don't think we properly understand that. So in parallel to these trials, I think we also need to get a better understanding of how we can robustly and sensibly generalize from one context to another, not to undermine the case for trials, but to help us to translate that information.
And the one thing I would add, and I add this as a academic, as a professor, and as a mentor to students, is that I think this is also an area where we have an opportunity to come up with innovative methods, to think about what methods can we use in contexts where full-on RCTs may be challenging. What are other methods? What other, both statistical as well as methodological models can we come up with to really continue to learn about programs? What are the new innovative statistical techniques and as well as programmatic techniques for doing implementation research? So I think that we need to make sure we're not getting stymied in terms of services by the gaps, but that we always keep in mind that building evidence is a process and that evidence can continually be built as programs are implemented, and we have techniques to start doing that.
Hello. I want to talk a little. My name is Vivi Stavro. I work for REPSI, Regional Psychosocial Support Initiative in East and Southern Africa, and also live and work in the States. And I want to talk a little bit about the triangle that you presented with the sort of tertiary services, psychiatrists, psychiatric hospitals, and then the need to shift our services, task shifting towards the more community-based and preventative and advocacy programs. Absolutely, wholeheartedly agree. I think we've made the point there's enormous amount of, well, I don't know about enormous amount of evidence, but we've made the point developmentally and from a health point of view, that's the way to go for better health. However, I come from, and most of my life have worked in East and Southern Africa, and in particular evaluate community-based mental health and psychosocial programs, and in particular in conflict, post-conflict areas, emergencies, and working in the area of child protection. And very often the huge block that we get is the ability to refer on to skilled people, the ability that to examine quality of care, that harm is not done because there's such a dearth of specialists at the different levels of tertiary and secondary care, of people coming from African institutions, low-income countries, institutions there, of resources going there and staying there. So many of us live in the developed world and stay here. And I do think it has been that is neglected. that for young people coming into the field, we are focusing our attention on building up community-based services. So much of that is family care. The staggered ladder of training, we're on the sort of 4th and 5th level now, where non-professionals, community workers are training other community workers, are training families to do really, really complex work in communities. And there's very little substantive supervision going on. And I just see increasing harm being done, and very little honest discussion and rigorous evaluation around that, and a huge promotion of such programs, which, yes, developmentally do make sense, and we have spoken about protocols and rules, and policies are there, and it's a new and emerging field. But equally, I think we need to be far more rigorous in our evaluation and our ethics and protection issues around that level of community-based care.
I couldn't agree more. I couldn't agree more. I think what you raise is also there's a bit of a divide between the psychosocial and the mental health. And I think some of the work, I think it's Judy and Paul that they did in northern Uganda. They evaluated 2 programs, and one of them was the play therapy. And that was found to have no impact at all. So on the one hand, there may be programs that do damage, and on the other, there are programs where a lot of money is probably going, but it has no impact at all. And yet here we are looking for more funds for mental health. So the issues that you raise are really important. And I think on the mental health side, that rigor is there. I think we do have that rigor of trying to measure outcomes and to measure effectiveness. But on the psychosocial side, because 1, the funding comes from a different source, and 2, because often people go in when it's an emergency, and that's a whole different approach from when it's a regular program activity. And so in an emergency, it's a whole different approach. And those who go in also go out very quickly because another emergency comes up and their mandate is emergencies. So they'll go in and they'll go out very quickly. And so that side of it is rather weak, as you say. And I think because of that tension between ourselves, the ones that say we are mental health and we're psychiatric, and the other side that's more the social and psychosocial, until we begin to better work together so that we can provide the support that is needed across the 2 programs, but also to do evaluations like you're saying, and it's going to continue to be a problem. But
if I could respond quickly, yes, there is a difference between psychosocial and mental health programs, but equally I was talking about community-based mental health programs. And equally I think that even though there might be more internal protocols and standards and national-based standards, there is a definite increasing gap in terms of supervision and quality control of peer-led community-based programs.
My name is Lydia Turner. I'm a Mirror Research Assistant here at Hopkins right now, but I'm an aspiring researcher at one point. So I'm sorry if this question is somewhat surface level and somewhat tangential as well, but I was just wondering, since we've all noted that we have such limited resources at this point for mental health anywhere, how much of that should be devoted to education rather than treatment, not only to care providers and people that need care, but to the general population within any particular country. As well, you know, we talked a little bit about long-term outcomes and how hard those are to, I guess, measure. But I was just wondering what your opinions are on how much of our resources should be devoted to education rather than just treatment.
And I would just expand it a little bit to prevention systems, maybe, rather than just treating the people who have it, as opposed to prevention programs, which probably include education as well as other types of services.
Well, there are difficult issues there. Whatever evidence exists for public education as a prevention or public education as anti-stigma kind of activities is very limited, really. It doesn't seem that widespread and general public education does lead to very clear outcomes, at least in the areas where it has been investigated. So we are not really recommending that, but very focused programs on clear target groups like providers, like within the education system, they seem to have some use, and that should be done. But the other issue which Judith is raising is the socio-economic and other policies of the government which need to change, and that might lead to very clear prevention mechanisms. And that's something that we need to investigate more, but there are clear evidence that that is a very attractive and rewarding kind of activity, which we must go ahead and explore more, because again, clear evidence is not available. Do anti-poverty activities of governments, and remember that a number of developing countries have anti-poverty programs where there is some income support, some microcredits and all those things. Do they lead to better mental health? The reasonable assumption is that they do, but hardcore evidence is still lacking. And that's another area where evidence needs to be aggregated for doing that. So that's my short answer, but obviously this is a very big area.
Thank you.
I mean, just a quick response. I mean, as an economist, I always used to joke that every 2 weeks I get a phone call from a drug company saying, could you help us with this study or that study or whatever else? And that's dried up now. And what we get now every 2 weeks is, and I've just made a list of the 5 that have come up most recently, we get calls, emails from community organisations, from government organisations. I mean, the ones that have come up is, can we help them to build an economic case for building community capacity, for reinforcing social capital, for prevention, primary and secondary, for co-production, for social inclusion. These are all, so the big change, given the changed economic circumstances, is can we, in our case, provide evidence to help them to invest in, or to persuade others to invest in these preventive, education and other initiatives. And I think, you know, there is a case to be made, but it's not been a case that's been looked at too much in the past. So I think things are changing in the way you're saying.
My name's Elena Berger, and I work for the World Federation for Mental Health. I've got a question about the quality of mental health research in low and middle income countries. And it comes from a research group in Canada. It's called Prevail, and it works on domestic violence and child maltreatment. And the question they wanted me to ask is, what about research in low and middle income countries that doesn't meet the very high standard of research we've been discussing this afternoon? Dr. Saxena has an atlas book about the real problems of research in very isolated circumstances in a lot of countries. Is there some way to capture that information, and should it be assessed in different ways? Could you talk about that a little bit?
I would just say one comment would be that this plea for capturing that information is something that we often share with our collaborators, the NGO collaborators and the groups we work with, to say, even if you haven't done RCTs, even if you haven't done this, there's value in documentation processes, in documenting lessons learned, in documenting skills built and things like that. And so I value what you say, because it's an argument or a discussion that we often have, which is that we need to learn more about what is actually going on, even when it's not full-on RCT research.
I think, as Judith is saying, there are various kinds of evidence that can be collected, and I think we should not disregard some of the more descriptive, some of the more softer approaches, because they can contribute a lot to the evidence base. And so it's not only the most sophisticated research, I think it should be the more simple research which should be more encouraged. And obviously there is so much lack of research from low and middle income countries, but also very low level of resources for research also, that I think we need to make some kind of adjustment on what is the kind of research that is feasible but is still of a standard that can contribute. Now, I would just add a footnote to what you were saying, if my interpretation is correct. It's not the scientific standard of research which is a problem. Sometimes it's the ethical standard which is a problem. And there we should not have any compromises. Very clear ethical standards for any research that is done in low and middle income countries is absolutely necessary. And I see some very worrying signs that that's not being done. So there we need to be very hard.
Just to add one more, I think it's possible to do research even in the low-income countries. It is possible even for NGOs to do this kind of research. There are the journals like Lancet, and there are also other journals that are going to publish this kind of research that you talk about. One of them could be like Interventions, that does publish different levels and different kinds of research because they're looking for work that comes out of the field. But I think also increasingly, the NGOs or those doing work in the low-income countries have got to be able to make that sort of investment. As an example, I'm doing some work with TPO in Uganda. This is a Ugandan NGO that was started as an offshoot of HealthNet TPO, and they used some of their program funds for activities. They asked their donors if they could do this, and the donors said yes, because the donors also want to see effectiveness of their interventions. So they are not using a lot of money. The interventions are provided by the intervention that the donor pays for. All they have to do is find a little money to pay somebody from a research institution. This time it is me. And yeah, and then I provide them with a little expertise, but they're using maybe their program staff as the research assistants, but to collect the data, to make sure, you know, so there are two other, myself and a biostatistician. So it doesn't cost too much, but then you do get a product, hopefully, that's going to be useful to many people.
My name is Jude, and I'm currently working as a consultant for USAID. Over the past couple of months, I've been developing mental health profiles for some countries, and the WHO report, the Mental Health Atlas, has been immensely helpful. I just couldn't imagine being able to do those studies without those reports. Now, my question is, I've been looking at to see if there's like an intervention package, and I haven't been able to see any comprehensive information in that respect. So I wanted to, my question goes specifically to Dr. Saxena. He mentioned while he was doing his presentation that WHO is currently working on that. So I wanted to ask, I'm really curious, when would that information be available? And if so, if it's going to be on the internet, like what link, and I'm really searching for that kind of information. And then my next question goes to Dr. Judy, even though she said, we're supposed to ask the 4 speakers, but let me break the protocol here. A lot of information has been provided, which I think some of which I haven't been able to capture. So how are we going to get, the various slides as a group, or particularly I'm interested in getting that.
Well, I haven't discussed with the speakers yet about the availability of the slides, but I can follow up on that. A tape, this is being audio and video taped, and it will be available online.
Okay.
And so you're always welcome to go back and zip through the parts that you're interested in and follow up and things like that. But I will discuss with them about the availability of slides by request.
My slides are available. They are in public domain. No problems.
Okay.
Thank you for using Atlas. And intervention package will be available in its field trial version by the end of April. So it's only a month and a half. So
our last 2 questions we'll do quickly.
Very quickly. My name is Melissa Scher, and I work at JSI, John Snow. I'm working on the Aid Star project, and so Jude, I'll talk to you afterwards, which is USAID funded. And we're trying to develop a database based on delivery mechanisms, so a practical database that looks at how HIV, how mental health can intersect with HIV care and support programs. So any type of practices that you're doing, the woman from Project Concern, some of the different stuff that all of the panelists are involved with, if you could just Google G3P, which is good promising programmatic practices, and we're trying to build a database from the ground up, i.e. from the people who are doing the work on the ground, who know what works, who talk about delivery mechanisms, and then they can provide different tools for other people to adapt to their setting. And it's like about inverting the triangle the other way, so it's coming from the ground up. And so please, I just encourage you to look into that and to try and document some practices. And I've talked to some people on the panel about making sure some of this great work is getting out there, because just recently, in the last 3 months, I've talked to 2 different people who've taken the ASHA example from Goa, one in Liberia who's applying it to mental health, HIV, and epilepsy in Liberia, and then over the break, a woman who's doing work in Haiti. And so again, the more that we can get these models out, the more that we can replicate them, and at the ground level, which is really important, I think. The final question, very quickly, is just social workers and trying to get this cadre more professionalized, and because they are the people who can help us invert the triangle and making sure that the community care. And I just wondered if there are any examples that you know of. Again, just in the past 3 months, I've talked to people in Vietnam who are doing case management. Ethiopia is doing a case management program to increase adherence to, again, looking at the community level and increasing that, and what your experience has been with, more professionalizing social work in your countries.
Okay, just taking again the example from Uganda, we've just done a baseline survey. That funding that we got from the African Development Bank ended, and we got a new grant from the African Development Bank. So as a baseline survey of that, in June, July last year, we did a baseline survey, and this was to establish more the resources that were already in place in order to see where the gaps are and where we need to change. And one area that we looked at was social workers, and unfortunately, there's a huge gap area there. And there's some training. I think that one of the big challenges is that we don't have training for psychiatric social workers in Uganda. So the older ones that we had trained in the UK, and they've slowly either retired or they've died, and so we don't really have anybody who's a real trained psychiatric social worker. And the social workers who we have, I think the challenge that they have is they're not really trained to work with people with mental disorders. And one of the big programmatic areas was very often the health units were able to deliver the mental health services within the healthcare unit. But when it came to reintegration of patients into the communities and providing the community-based mental health interventions, that's where there was another huge gap. So it's obvious that that's a huge gap area that will have to be addressed. So maybe if you get answers, you'll pass them on to me as well.
Take a final question.
Oh, that's difficult.
No pressure.
I'm Milton Weinberg. I'm a psychiatrist, and I do HIV research in Brazil. I'm going to make it brief because I could speak for hours, but do work whatever you do and try to integrate as many people as you can. Call families, call consumers, call politicians, and find out who are going to be the next ones, because they're going to change the government and they're going to change the providers. So you need to include them, and that way you prepare for the next 5 years. We started by a pilot feasibility of adapting an intervention for psychiatric patients, HIV prevention intervention for psychiatric patients. There was not one intervention anywhere that was considered the best intervention to be used. We decided to create a model of how to integrate all of those that showed some evidence. And we're doing now an RCT in Brazil, but we somehow got connected with everybody. And don't ask me why. Maybe we had some drinks, because of caipirinhas are very good in Brazil. So I really recommend talk with anybody. I knock doors, and then I invited them to spend a year with us at Columbia, et cetera, et cetera. One of my, Judy, you proposed what the next year should be the conference, which is what are the different models of research, methods of research to do? Because if we do pilots, then RCTs, and then effectiveness, then implementation and dissemination, it happened 10 years ago, what we should be doing. And at the same time, I think that we need to learn from history. We're putting a lot of emphasis. So one is the methods, because many of us don't know those methods and wants to learn them and don't know where to learn them. And the other is history. The the RA that talked about education and prevention, I hope she's still here. You know, in HIV, I always had this joke that if the Pope would have one Sunday not say anything, but just open a condom and say this and go like this, it would have been the best HIV prevention intervention in the Catholic world. And nobody would have been able to test it. When in the gay community was people saying, come out, is changing how in some countries there is a perception with regards to gay people. So, and not everything we can test in an efficacy trial. So there is, and we know that, you know, when Magic Johnson was HIV positive, it made some people, but nobody followed it up. We didn't do enough to follow up. So wasn't it the Lancet that also had that if you don't need best evidence to know that you need a parachute to jump from a plane? Wasn't that an article? Okay. So there's a point that we need to use common sense, not for interventions, I agree. Interventions, we need to know what we're doing. But there are a lot of things that we need to combine with that. So the method, I don't know if you're going to do it next year, but I'm just proposing it for you, is how do you combine those things together? Because you need to move the community. The stigma, the lack of human rights will not change with interventions, but it will change with Magic Johnson, the Pope, and other people that can do things. And you're doing a phenomenal work. We need to all continue doing it. Thank you.
Well, unless there's a specific comment, I think that's a great way to end our symposium. So before we go off, I have a few people that I must thank. Of course, we need to thank Dr. William Eaton, the chair of the department, for supporting this symposium. But I think you would agree with me that even more importantly than thanking Dr. Eaton is thanking Jamie Tironi, who I had lots of email and conversations with, but I think many of you probably also had lots of emails from and with as she helped make sure this happened, both logistically as well as technically. So thank you, Jamie. A little plug for a work in progress. We, many of us from a variety of different departments and institutions within the Johns Hopkins Medical Institution are getting together to put together this global mental health web portal, which will have access to a lot of different mental health services and research going on throughout the whole school. It's a work in progress, so check back often. And then finally, to announce next year's symposium, although I would love to have suggestions for next year's symposium, I'm excited to say that the focus is mostly going to be on prevention activities, looking at issues around design, methods, applications, and Dr. Catherine Bradshaw from our department will be putting this together. It's proposed to be for May of next year, and probably a full-day event. So you're on the mailing list now, so if you're interested, please come back again next year. So please join us in thanking all of our speakers for coming from so far. And please join us as we continue the conversation around some wine and refreshments in the same room as where we were before. So thank you all for staying.